Welcome to our introduction on MR of neuroanatomy. I'm going to start out with a very basic approach to neuroanatomy with a sagittal, flare, three-dimensional 1 millimeter image in the midline showing you the brain stem, the medulla with the medullary clava, the medullopontine sulcus, the pons, the midbrain, and you see the mammillary body is a nice little landmark anterior to it. There's the pituitary gland and fossa. And we're going to drill into each one of these subjects separately. We've got the collicular plate, the inferior colliculus, and the superior colliculus. Behind that is the cerebellum with the lobes of the vermis lying below the tentorium cerebelli, and there's the straight sinus and vein of Galen. Now just above that, if we scroll a little bit, we've got the occipital lobe, responsible for vision with the calcarine sulcus. Separating the occipital lobe from the rest of the brain, including the cuneus and the precuneus, is the parieto-occipital sulcus. So this is the boundary between the occipital lobe and the parietal lobe. Now let's go out a little bit to the side for some just very gross anatomy, looking at the frontal operculum and the temporal operculum and the sylvian fissure, which is shaped a little bit like a caterpillar, and it separates the frontal lobe from the temporal lobe. Now there are some very specific areas of anatomy that we'll talk about, including Broca's area, in a separate vignette in the anterior frontal lobe. The separation of the frontal lobe from the parietal lobe falls to the central sulcus of Rolando. So here's the precentral sulcus. I'm going to show you in a few more vignettes how to identify it. There is the central sulcus. Here's the precentral gyrus, which is bigger than the postcentral gyrus. So the central sulcus, now we follow it off to the midline. There it is. There it is. It's a little hard to see in the midline. It has more of an oblique configuration to it, so we kind of lost it a little bit. It's right there, actually. That will separate the frontal lobe from the parietal lobe. You can see there's a lot less parietal lobe right here than there is off to the side. If we go back off to the side, there's a lot more parietal lobe. Let's go back to the central sulcus of Rolando. It's right there. So this would be frontal, this would be parietal, this would be occipital, and this would be temporal. Now, one other thing you should be aware of is that these sulci, they don't go straight up and down. They're oblique. So depending upon where you are from top to bottom or how you angle, if you angle this way, things are going to look different than if you angle like a CT this way. And we'll talk about those differentiators and how to identify specific anatomy based on those varied angulations in a separate vignette. So I've given you a rough idea of the brainstem, the cerebellum, the occipital lobe, the parietal lobe, the temporal lobe, and the frontal lobe, and given you the means to distinguish their locales. Let's move on, shall we? I want to talk to you a little bit about the frontal lobe, which is the behavioral, personality, and also the inhibitory area of the brain. It's responsible for impulse control. And let's start out at the level of the sylvian fissure, which looks a little bit like a centipede or a caterpillar right there. There are the antennae of the caterpillar. There you see the body of the caterpillar going back, and here's the tail. Now just above that, we've got the inferior frontal gyrus and the inferior frontal sulcus. Now if there's an inferior one, there must be a superior one, right? Well, here's the inferior one. Let's draw over it, the inferior frontal sulcus. And if we kept going and we scrolled inward and we weren't volume averaging against the direction of the sulcus, we would see another one, the middle sulcus, and then another one above that, the superior sulcus. We'll see these in the coronal projection much better. Now sometimes the middle one is divided up into two parts. There are two sulci creating a couple of lobes of the middle component or the middle gyrus of the frontal lobe. But I'm going to focus on the inferior portion of the frontal lobe, namely the inferior sulcus and the inferior gyrus. Just below it is going to be the sylvian fissure, and just below that is the temporal lobe. So we are dividing up the frontal lobe from the temporal lobe. To find the entire temporal lobe, you've got to go up and back to the central sulcus of Rolando. And I'm going to help you find the central sulcus of Rolando right now. So let's take the inferior frontal sulcus and follow it back. And here's this staircase descending structure. Often these two don't communicate with each other. But here you see it kind of descending like a little staircase right here. And right behind it is the precentral gyrus. So precentral sulcus, pointed to by this structure, precentral gyrus. Yes, there is a little small sulcus inside that. The precentral gyrus is always going to be bigger than the postcentral gyrus. The precentral gyrus and the postcentral gyrus are separated by the central sulcus of Rolando. The central sulcus of Rolando, up and back, separates the frontal lobe from the parietal lobe. There's some of the parietal occipital sulcus separating the parietal lobe from the occipital lobe. Now let's go back to the frontal lobe, and if we look very carefully, we have created along the top of these antennae, here is the anterior horizontal ramus and anterior ascending ramus of the Sylvian fissure. Right above that, the letter M. I'm going to draw the M right here, just so you can see it. Here is M, or maybe a heart if you want to have extreme imagination. And that is the area known as Broca's area, specifically in the back. Now, the front part is called the Pars Orbitalis. It's going to abut the orbital gyri. This is Brodmann 47. The Pars Triangularis, yes, it is triangular, well named in the middle, Brodmann 45. The Pars Opercularis, or opercula, is in the back, which is the start of the frontal operculum. This is Brodmann 44. Officially Brodmann 44 and Brodmann 45 in the dominant hemisphere, which is usually on the left side, forms Broca's area. Now let's go back to the central sulcus for a minute. Here it is. Here's the central sulcus, and work our way towards the midline. You're going to see how hard it is to follow it continuously all the way back. We're still following it, and we've got it. It's this little oblique slit that is found just anterior to this structure right here, which is composed of the cingulate sulcus and the supramarginal or marginal sulcus right here. So once you find this long, stringy sulcus that goes into the cingulum, right in front of that, the oblique, dark area seen anterior to it is the central sulcus of Rolando in the midline. I'd like to share with you a little bit of the anatomy and the surrounding neuroanatomy of the Sylvian fissure and the superior temporal sulcus. So let's start out in the midline, basic. We've got our cerebellum, we've got our cuneus right here, our precuneus right there, and then our paracentral lobule. In the region of the paracentral lobule is the central sulcus of Rolando, which can be easily landmarked and found by identifying this marginal sulcus, which is the continuation of the cingulate sulcus. Now, as we scroll off to the side, we suddenly and without warning lose our central sulcus of Rolando. We're going to get it back in a second, and it has come back right here. So here's the central sulcus of Rolando. In front of it is the precentral gyrus, which is bigger. The postcentral gyrus is smaller. And let's go to our Sylvian fissure for a minute. Our Sylvian fissure, shaped like a caterpillar. Here's the anterior horizontal ramus, anterior ascending ramus, posterior ascending ramus, and maybe a small posterior descending ramus. Over the top of it is the supramarginal gyrus. Over top of that is the intraparietal sulcus, kind of shaped a little bit like a bird, if you will, or a horseshoe. Kind of looks like this. There's another portion of it we don't see as well that comes around this way to cap this structure, and that structure is the superior temporal sulcus. The superior temporal sulcus separates the superior temporal gyrus from the middle temporal gyrus. Now, capping, or horseshoe-like on top of the superior temporal sulcus is the angular gyrus. The angular gyrus and the supramarginal gyrus together form the inferior parietal lobule. Above this sulcus will be the superior parietal lobule. Superior parietal lobule, inferior parietal lobule, separated by the interparietal sulcus. Supramarginal gyrus, angular gyrus, forming the inferior parietal lobule. And the components described for the Sylvian fissure separating the frontal lobe from the temporal lobe. Let's move on. I want to talk a little bit about the middle frontal gyrus, which serves as a nice landmark to identify the precentral sulcus. Let's start out down low in the frontal region. We've got the letter M, the pars orbitalis, the pars triangularis, and then the pars opercularis. Now let's take that away. That's the inferior frontal gyrus. Let's scroll a little bit more towards the midline. Right above this sulcus, the inferior frontal sulcus, is the middle frontal gyrus. Now, the middle frontal gyrus can be divided up into two. It's the thickest of the frontal gyrus. Sometimes there's an extra sulcus running right through it. We don't see that here right now. But it does point to a space, and then that space gives rise to a sulcus, the precentral sulcus. For right now, pay no attention to this horizontal sulcus right here. So immediately behind that would be the precentral gyrus, bigger than the postcentral gyrus, and now you have your central sulcus of Rolando. So that's one way to get to the central sulcus. Now, the central sulcus of Rolando does not communicate with the Sylvian fissure. This area right below it is called the subcentral gyrus. In the next vignette, I want to come back to and have a brief separate review of the intraparietal sulcus and the inferior parietal lobule. Let's talk about the superior and inferior parietal lobule, especially the inferior parietal lobule. Just to get you oriented, here's your staircase descending precentral sulcus, which means this has to be the precentral gyrus, which means that is the central sulcus. That is the subcentral sulcus. Remember, these two, the Sylvian fissure and the central sulcus, don't communicate. And there is the postcentral sulcus. There's a method to my madness, because the postcentral sulcus becomes this structure, an arcuate shape or horseshoe-shaped structure called the intraparietal sulcus. Sometimes I use the term interparietal, which is actually technically incorrect, so forgive me if I do. The intraparietal sulcus. Above that is going to be the superior parietal lobule, below it the inferior parietal lobule. So let's say it again one more time. I know you're listening on tape, so you can review it again, but there is the postcentral sulcus, central sulcus. Postcentral sulcus is the upswing of this arcuate shape, there it is again, this arcuate shaped intraparietal sulcus. The intraparietal sulcus separates the superior parietal lobule from the inferior parietal lobule. What's in the inferior parietal lobule? Well, right above the Sylvian fissure, supramarginal gyrus. Right above the superior temporal sulcus, the angular gyrus. Inferior parietal lobule, you got it. Let's successfully isolate in the axial projection the central sulcus of Rolando. Let's start out by turning the brain into a little bit of a map. We're going to bifurcate the brain right down the center along the falx, and we'll call this 12 o'clock. We'll call this 6 o'clock. And then at the level of the widest biparietal diameter, we'll have 9 o'clock and 3 o'clock. So now let's keep that in our mind's eye. We've got a sulcus right here, which represents the superior frontal sulcus. Let's follow the superior frontal sulcus back, and we follow it into, all the way up high, this is part of the superior frontal sulcus, the precentral sulcus. So if we've got the precentral sulcus, we know that's going to be the superior frontal gyrus, middle frontal gyrus, precentral sulcus, precentral gyrus, central sulcus of Rolando, the precentral gyrus bigger than the postcentral gyrus. Behind that is the postcentral sulcus. Now, we said before, the postcentral sulcus is the upswing of the intraparietal arcuate-shaped sulcus. It divides the brain into a superior parietal lobule here and an inferior parietal lobule here. In the inferior parietal lobule, you have the supramarginal gyrus and the angular gyrus. So let's summarize one more time. The central sulcus of Rolando can be isolated by finding the upswing superiorly of the superior frontal sulcus into the precentral sulcus. From there, it's easy. Precentral gyrus, central sulcus, postcentral gyrus. If you are a disbeliever or skeptical, we spent many vignettes isolating the central sulcus of Rolando in the sagittal projection. There it is, and it is consistent with our model. There's our precentral sulcus, there's our central sulcus. You can see they cross-reference very nicely. Isolating the superior frontal sulcus, following into the precentral sulcus, allows you to locate the central sulcus of Rolando. I'd like to isolate the intraparietal sulcus in the axial projection. There it is. If we cross-reference that arcuate-shaped structure in the sagittal projection, there it is. There is our intraparietal sulcus, which is arcuate or horseshoe-shaped in the sagittal projection. It's a nice localization because anterior to it is the central sulcus of Rolando. So it helps you find the central sulcus and the post-central gyrus right in front of it. The intraparietal sulcus separates the parietal lobule into a superomedial supraparietal lobule and an inferolateral inferior parietal lobule. The inferior parietal lobule consists of, in the sagittal projection, the supramarginal gyrus around the Sylvian fissure and the angular gyrus, which sits around the superior temporal sulcus. These two form the inferior parietal lobule. They kind of make a little bit of a horseshoe shape around these two structures, one there and one there, the inferior parietal lobule. So in the axial projection, behind the central sulcus of Rolando, the intraparietal sulcus dividing up the superior and inferior parietal lobule. I want to give you another tool to localize the intraparietal sulcus. First, I'd like to draw it in the sagittal projection, and then I'll show you this sign that you can use. So here it is as an arcuate-shaped structure. Remember, you don't see the whole thing because it's so convoluted and involuted from the surface of the brain. It's very deep. But if I were to show you exactly where that spot was by cross-referencing it, it corresponds right to this locus right here. Now we see part of it on this one cut. And if I was to take the brain, as we did before, and divide it up into 12 o'clock and 6 o'clock, then we have at the widest biparietal diameter, we've got 9 o'clock and 3 o'clock, something like that. And then we're going to take this sulcus, which goes from 3 o'clock, and it usually lands somewhere around here at around 5 o'clock. And then on the other side, this would be 7 o'clock. We can actually see it here at 7 o'clock. Now, 75% of the time on the left side, this intraparietal arcuate-shaped sulcus is continuous. In this case, it's a little bit broken in the back. On the right side, it's a little more disorganized, so it's hard to pick it out from the 9 o'clock to the 6 o'clock position. So it's a little easier on the left, and then you extrapolate on the right just to make it work. So if I take these lines away, you can see it now. There it is right there, going from 3 o'clock to approximately 5 o'clock, maybe a little bit past 5 o'clock in the posterior aspect of the left parietal region of the brain. The intraparietal sulcus, the clock face sign for identifying it as the divider of the superior and inferior parietal lobule. I want to give you another tool for locating or localizing the intraparietal sulcus. Let's bifurcate the brain as we have in prior vignettes. Let's use the 12 o'clock designation anteriorly. We'll cut the brain in half. 6 o'clock in the back, widest biparietal diameter, 9 and 3. This would be 5 o'clock. This would be 7 o'clock. We already said in a prior vignette that coming out at the 5 o'clock position is the back portion of the arcuate-shaped intraparietal sulcus. Now, on the left side, 75% of the time, it's continuous. On the right side, it's frequently broken. So you may only see the exit, and you may have to gerrymander it or infer it from looking at the more consistent left side. Now, another way to go at this is to look at the sagittal projection. Here's the operculum, and right in the back is the staircase descending precentral sulcus, precentral gyrus, central sulcus of Rolando. Let's tap that. Cross-reference it. Now you got your central sulcus. If you got your central sulcus, easy. Precentral gyrus, postcentral gyrus, postcentral sulcus. Now that you have postcentral sulcus, you know that it's the upswing of the intraparietal sulcus, so that must be the intraparietal sulcus. Therefore, that has to be the superior parietal lobule, that has to be the inferior parietal lobule, and you're home. Let's talk about the gyral and sulcal anatomy and the midline sagittal projection. We have a terrific landmark, namely the corpus callosum, with the lamina terminalis, the rostrum, the genu, the body, and the splenium of the corpus callosum. And the orientation of the anatomy is somewhat radial to a central structure, kind of the center of the clock, which is the foramen of Monroe. Now, if we follow the cingulate sulcus around and back, it exits about 2/3 of the way back on the brain near the midline or at the midline, and this is known as the Pars Marginalis. A terrific landmark it is because just anterior to it is this perpendicularly shaped structure, perpendicular orientation to the Pars Marginalis, kind of obliquely oriented, the central sulcus of Rolando. Now, another structure is the paracentral sulcus just anterior to this. You can either find it coming from the top in front of the central sulcus or coming from the bottom, as it does here, and followed around as the continuation of the cingulate sulcus, and this is known as the paracentral sulcus. That's relevant because this is the paracentral lobule. So you've got cuneus, precuneus, paracentral lobule, paracentral sulcus, central sulcus, pars marginalis or marginal sulcus, and the cingulate sulcus with the additional anatomy already described. Pomerantz out. Let's take a look at the parieto-occipital sulcus, which separates the occipital lobe from the parietal lobe. Here it is. It looks a little bit like the letter Y lying on its side. Here's our Y right here. And it merges with this calcarine sulcus to form the anterior calcarine sulcus. Now, the structure in front of it looks a little bit kind of like a tongue of beef right here, right there, is the continuation of the cingulate sulcus. Now let's take our arrows away for a minute, or our lines away. We've got the occipital lobe and the cuneus. In front of that is the precuneus. And within the precuneus is something that looks a little bit like the letter H. There's our H. And this is the subparietal sulcus, located in the precuneus. In front of the precuneus is the paracentral lobule. Within the paracentral lobule is the oblique perpendicular to the marginal sulcus, central sulcus of Rolando. This paracentral sulcus, which we discussed in another vignette, which comes up anteriorly, forms the anterior boundary of the paracentral lobule. All of this contributing to the frontal lobe until we get to the central sulcus of Rolando, which defines the parietal lobe posterior to it, which is a tough designation to make in the sagittal near the midline. So frontal lobe, paracentral lobule, central sulcus of Rolando, a little bit of the parietal lobe, precuneus, subcentral sulcus, cuneus, occipital lobe, superior and inferior, calcarine sulcus merges with the parieto-occipital sulcus to form the anterior calcarine sulcus, and there's the beef tongue of the cingulate gyrus. Let's take a look at the pars marginalis in the axial projection. Now, if I were to localize the pars marginalis in the sagittal projection, the continuation of the cingulate sulcus following it on up to the pars marginalis or marginal sulcus, that corresponds to these two foci that look a little bit like a kind of a droopy mustache, if you will. Perhaps Salvador Dali's mustache. Now, if we were to look at how we would acquire CT cuts, so we would acquire them obliquely like this, that would mean that the marginal sulcus or the pars marginalis kind of has the same position as we go from caudad to craniad in the axial projection. On the other hand, if we are acquiring MR images, they're going to be in the orthogonal projection. So let's once again draw the pars marginalis. This time we have orthogonal cuts. Let's just change color to make it really clear. If we're going this way, look at what happens to the pars marginalis. As we go up, it goes more posterior or sits more posteriorly. Now let's look in the axial projection. Here we are down low in the pars marginalis, which is this ascending sulcal structure right here. We have our droopy mustache, and then as we go up, the mustache is a little bit straighter. It's also found at the widest biparietal diameter at the 9 o'clock, 3 o'clock position. Typically is where you're going to see the pars marginalis, and there it is. Our mustache is getting a little bit straighter. Let's keep going more craniad, and now our mustache is kind of flipping up a little bit like Salvador Dali's mustache that's no longer drooping. And why is this important? It's important because just anterior to the pars marginalis is the central sulcus. And this little notch right here in the precentral gyrus is the hand motor area of the left cerebral hemisphere, similarly on the right side. The central sulcus of Rolando sits anterior to this little basket right here, so it kind of pokes its way just in front of the pars marginalis, while directly behind it is the post-central sulcus. You all know from prior vignettes, if you've watched them, that the post-central sulcus is the upswing of the arcuate-shaped intraparietal sulcus. So we've got post-central sulcus, precentral sulcus, precentral gyrus, post-central gyrus, hand motor area, pars marginalis. And the pars marginalis looks a little bit different on MR than CT for reasons previously discussed. Pomerantz out. Let's take a look at the sagittal midline cut, the guts, the heart and soul of MRI of the brain, where you might use this sequence to evaluate, and especially this projection, to look for anomalies of the brain in pediatric patients. I want to talk about the commissures. So I'm going to start out with the inferior colliculus, the superior colliculus, and I run right into the posterior commissure, which is a pretty small structure. And right above it is the habenular commissure, sitting between it, the posterior commissure, and the pineal gland, which is not a commissure. Another commissure is the interthalamic adhesion, which you can scroll back and forth, the midline portion of the thalamus. A well-known commissure anteriorly is the anterior commissure. And then the largest commissure, the granddaddy of them all, is the corpus callosum. We look in the midline, we see a vertical slit-like area of hyperintensity right there, the lamina terminalis and the rostrum of the corpus callosum, followed by genu, body, and the splenium of the corpus callosum, which you're all familiar with. And as long as we're in the neighborhood, we've got the body and crus of the fornix, and then the fornix itself. We'll move on now to some of the other structures in the midline if you have time. Sagittal midline anatomy, focusing on the brain stem, the medulla separated from the pons by the pontomedullary sulcus. Another little dippity-doo or sulcus can be seen at this protrusion here, which is a landmark known as the medullary clava, where the proprioceptive nuclei will synapse. Anteriorly in the medulla will be the location of the pyramids and the motor tracts. As we ascend, we reach the level of the pons with the pontine belly. The floor of the fourth ventricle, here's the fourth ventricle with the fastigium of the fourth. There's the inferior recess of the fourth. There's the superior recess and aqueduct of Sylvius. And the facial colliculus bump sits on the floor of the fourth ventricle, not easily seen here. As we move up to the level of the midbrain, separated by the ponto-midbrain sulcus, we see the inferior colliculus, the superior colliculus, the posterior commissure, and the aqueduct of Sylvius. Anteriorly, we've got the mammillary body, the interpeduncular cistern, through which the third nerve will be seen exiting on higher resolution imaging, and we'll show it to you separately in the cranial nerve section. If you look very carefully, you can see a little white structure ascending from the region of the mammillary body, and this is known as the mammillothalamic tract. That concludes a brief discussion of the brain stem, including a little bit of the ventricular anatomy. There's the third ventricle sitting immediately above it. Let's move on. Pomerantz out. Let's take a look at the cerebellar vermis on the sagittal midline with some magnification. Just to get us oriented, here's our fourth ventricle with the fastigium of the fourth, whose shape and pointedness and size we pay close attention to. Here's the inferior recess of the fourth, the floor of the fourth, where you'll find the facial colliculus bump, the inferior colliculus, the superior colliculus, the posterior commissure, the habenula, and the pineal gland. Behind the cerebellum is the straight sinus, and above it the vein of Galen, the tentorium cerebelli, and the falcotentorial region coalesce in this position. Inferior to the cerebellum is the foramen magnum. If we draw a line from the tip of the basion to the tip of the opistheon, we like to see the cerebellar vermis above that line. But it can lie 3 or 4 millimeters below that line, as long as, I'll draw it again so you can see it a little better, maybe with another color, as long as the cerebellum is not compressed, is not squished from anterior to posterior. And as long as the cerebellar tonsils are nice and round rather than being peg-shaped. If they're peg-shaped, then we have to worry a bit about Chiari malformation or one of its lesser variants. Now let's turn our attention in the midline to the cerebellar vermis. We've got a small structure initially, anterosuperiorly, the lingula. Then the next structure is going to be the centrum. I'll use yellow for that. Then the largest, the granddaddy of them all, I use blue, is the colmen. It's the biggest lobe of the cerebellar vermis. Then we get into three lobes that are kind of hard to separate them out here. We've got the declive, the folium, and the tuber corresponding to this lobe. And so declive, folium, and tuber, we'll say declive, folium, tuber. Then underneath that, and slightly anterior to it, we have the pyramis, or the pyramidal lobe of the cerebellum. And then we get into the last two lobes, which we'll use light blue for, the uvula, and then the one all the way anteriorly, we'll make a different color just so you can pick it out in purple, the nodulus. And here is the tonsil of the cerebellum sitting right above the line drawn from the tip of the basion to the tip of the opistheon. That's the normal anatomy of the cerebellar vermis in the sagittal midline, Pomerantz out. Let's take a look at cisterns and spaces on the sagittal thin section flare image. Let's start down low. We've got the cisterna magna at the level of the foramen magnum, anteriorly the inferior premedullary cistern. Here's our fourth ventricle with the inferior midline opening, the foramen of Magendie. Just anterior to it is a little bump here, the medullary clava, and the obex as a landmark. The fastigium of the fourth ventricle is pointed posteriorly, and its development and pointedness should be pointed out. Above, the fourth ventricle continues as the aqueduct of Sylvius. Above the cerebellum, the supra or superior cerebellar cistern, the cistern of the vein of Galen, and the peripineal cistern. Anteriorly, the interpeduncular cistern through which the apparent exit of the third nerve can be found, with the prepontine cistern off to the side will be the peripontine and perimedullary cisterns, and off to the side you'll find the foramina of Luschka at lateral recesses of the fourth. We don't see them on the midline cut. The third ventricle is a little bit squirrely. It's got a few recesses. Let's draw them in. We've got a recess above the pineal gland called the suprapineal recess, a little nubbin that bumps right into the pineal called the pineal recess of the third. Then as we come forward, we've got the suprainfundibular recess right here, and then we also have anterior to that the supraoptic recess in front of it. The four recesses of the third ventricle. And we've also got the suprasellar cistern, and volume averaged is the midline portion of the lateral ventricle. Those are the major cisterns that you see on a sagittal midline view, Pomerantz out. I'd like to take a look at the oft-forgotten blood supply of the midline. For many of us, think about the blood supply when we have medial lateral anatomy, like an axial or a coronal. But we see so many of these, and vascular disease on this particular cut can be a little confusing. By the way, pay no attention to this little finger-like projection, which is just volume averaging of a gyrus in the inferior frontal region. Let's start out with the anterior cerebral artery in red. I think you're going to be surprised at how far back it goes. We've already told you the frontal lobe goes up and back pretty far, but the anterior cerebral artery will encompass portions of the precuneus. So let's take that pretty far back, and then I need to take it down a little further, and I could color all this in right here, and this would be anterior cerebral artery distribution. Now, there's some variability in how the ACA and PCA intersect each other. I'm going to use kind of deep purple in honor of Jimi Hendrix to finish out the posterior cerebral artery. And the posterior cerebral artery will come down and encompass everything right up to the collicular plate right there, and then there are sometimes collicular perforators that may come from the back, and it stops just shy of the cerebellum. Then, to be anatomically consistent, we're working away from top to bottom. Let's go with a green color for the upper portion of the cerebellum, which is probably about half the cerebellum. That's going to be the SCA, or superior cerebellar artery. I should mark the PCA with PCA, just for your perusal and interest. The next stop is going to be pica, which is going to encompass the inferior cerebellar vermis and the cerebellar tonsil. And some of you are familiar with pica syndrome or Wallenberg syndrome, which is a pretty important one, especially for you medical students. Then we work our way into the region of the corpus callosum, and here we've got medial lenticular striates and callosal perforators, and these pretty much have their own locus. I'll use a light blue for this, and I'll color in the callosum. Although the back of the callosum is not supplied by these perforators, the back of the callosum, I should note, is supplied by the posterior cerebral artery. I'll give it a little deeper purple. So that's still posterior cerebral artery blood supply right there. Now let's work our way into the brainstem. I think I'll try something a little bit orange for the midbrain, and projecting from the midbrain up into the thalamus, pretty tall, almost columnar-like area, encompasses some of the mammillary body as well. I'll color it in, and that is the posterior choroidal and posterior thalamo-perforating arteries from the posterior cerebral artery circulation. So perhaps I'll label it as officially PCA, but there are perforates. They are not the main vessels that supply that area. Then we'll come down to kind of a deeper blue, and we're in the pons now. And these are perforating branches of the basilar artery, pretty simple. I'm not going to, actually I will draw them in. Basilar artery perforators, BAP. And now down to the region of the medulla of the brainstem. These are perforating branches of the vertebral artery. I'm going to use something a little aesthetically less pleasing, brown, and there you have it. The midline blood supply of the brain, oft overlooked. Pomerantz out. I want to take a moment to talk about the skeleton on the sagittal midline view, since everybody gets a sagittal midline view for brain MR. We've got the diploic space, which has variable amounts of fat in it, especially in the midline, where it's pretty much devoid of fat, as you frequently volume average the sagittal suture. And the sutural volume averaging can produce this little dotted appearance. I'll make it a little lighter so you can see it, of the diploic space. You've got an inner table, an outer table, and then the galea, which is visible inferiorly, but superiorly it hugs the outer table, so it's hard to separate out the galea unless it's lifted off by a subgaleal hematoma. Here is the superficial fascia of the scalp. There's the skin, and here's some subcutaneous fat. Then we have the tip of the basion and the tip of the opistheon, which define the foramen magnum. And then we've got the anterior button of C1, the atlantodental interval, which we pay careful attention to in rheumatoid arthritis, and the tip of C2. And there are some membranous and ligamentous structures we'll tackle in the cervical, spine, talk, and vignette. We've got the anterior arch of C1 as mentioned, and the posterior arch of C1, the posterior arch of C2. Don't forget to look at the sphenoid sinus and the frontal sinus. The clivus is a particular area of consternation. You can have synchondroses here. You can have bone islands here. You can even have recruitment of red marrow in this flat bone structure, and sometimes that may produce some consternation when you're considering the diagnosis of metastatic disease. However, typically, red marrow fades or becomes less bright on the T2 weighted image, and when you inject it and do first pass imaging or delayed contrast imaging, the enhancement is little to scant, and that will help you differentiate it from something of importance or significance. We're going to tackle in its entirety the brainstem skeletal anatomy in another series of vignettes. Pomerantz out. I want to talk about some miscellaneous structures on the midline sagittal MR that we frequently forget to look at. The pituitary gland is one of them. We've got the adenohypophysis, or pars distalis, and pars intermedia right there. The pars nervosa with a little bit of fat in the back. The pituitary stalk, or pituitary infundibulum, and the median eminence as it comes up and fans out a little bit. More importantly, structures that we frequently forget to look at, most of the time we don't forget to look at the pituitary gland, include the superior sagittal sinus, which will frequently have in-plane, slightly hyperintense, wispy flow. But it shouldn't look like a big, fat, intermediate signal intensity gray worm. And I'm going to make it gray intentionally right now. You'll see how hard it is to see, because when it's gray and smooth and you've lost any flow phenomenon, it's going to blend with the adjacent gray brain, and you're going to completely miss it. So be on the lookout for an expansile, solid, non-flow phenomenon area of gray signal throughout the superior sagittal sinus. This is absolutely critical not to miss. Anteriorly, you've got flow voids and in-plane flow phenomena in the basilar artery and in the basal plexus of vessels and or veins. You've also got anteriorly the nasal cavity, the sphenoid sinus and frontal sinus, discussed previously. One structure that is frequently overlooked, especially in an adult, 50-year-old or 45-year-old, is the adenoidal pad. The adenoidal pad should be virtually non-existent or flat. So when it's hypertrophied, you've got to consider things like lymphoid hyperplasia and even, in certain circumstances, if asymmetric, nasopharyngeal carcinoma. Don't forget to look at the uvula, the opening of the oropharynx, the base of the tongue. That's it for me. Pomerantz out. That concludes miscellaneous structures you should take a look at on your sagittal midline scout. Pomerantz out. We're going to talk about the cranial nerves. I'm going to start out with the first cranial nerve, the olfactory nerve, and begin with the olfactory mucosa. Now here is the olfactory tract and bulb as it starts to expand as you come more anteriorly. There you can see it a little better because it's expanding, and it's going to communicate with the mucosa. Now the olfactory epithelium is located in the anterior superior nasal concha, which is where we are. The concha are up in here, and it takes up about 2.5 centimeters cubed. Inside the olfactory mucosa are olfactory cells, and they're peripheral receptors that transmit pulses to the olfactory neurons. There are about 6 million bipolar cells called Schultz's cells, and they're distributed inside the epithelium. Their dendrites group together in filaments, which constitute the true olfactory nerve, and they cross the cribriform plate at the level of the ethmoid bone to reach this bulb. So there are little perforations here in the plate that allow the nerves of the mucosa here to communicate here. And when they get here, there's going to be a synapse. Now, if we just look at the olfactory bulb for a minute in the sagittal projection, so this would be anterior, this would be posterior. Coming from inside the brain are going to be several tracts. We're going to have a medial one. We have one that goes to the anterior commissure. We have an intermediate one. We're going to have a lateral sensory axon. And then these come back, and inside this bulb, these nerves are going to have a synapse. So I'll mark the synapse. There's a few of them. I'll mark the synapse with some other color. Let's go with red. So we've got a little synapse here. And then perforating, I'll use a different color like blue, after the synapse, perforating the crista galli, and then going into the nasal mucosa are going to be these neurosensory cells. And so the mucosa would kind of be here, bathed in these neurosensory cells in the nasal superior concha. As said, these neurosensory cells are called Schultz's cells. And this whole area, which I'll draw as kind of a big glob, even though it's a bunch of cells, 6 million of them to be exact, is called the olfactory gland. So it's not really a single gland. It's kind of spread out in the olfactory mucosa. And then you go backwards, get a synapse. Then after the synapse, the nerve filaments run posteriorly to form these tracts inside the brain in the axial projection. So if we looked at where the tracts are, let's go back to our drawing of the olfactory mucosa. Here's the gyrus rectus. Here's the medial olfactory gyrus. Here's the sulcus in between. And we draw the bulb right here in blue. Then it comes back. And then you'll have these bifurcations, one going laterally as the stria, one more intermediate, and one going towards the anterior commissure. And we're going to add another one to that is going to go over to the amygdala shortly. Let's move on. Pomerantz out. Let's talk about the olfactory bulb. We can see it on a coronal thin section image. There it is right there. A bulbous group of paired gray structures lying just above the superior nasal concha and nasal cavity. Do a little scrolling here. As we go back, you can see they spread out a little bit, become a little bit thinner as the optic tract. And we go forward, they're a little bit more round and bulbous and easy to see. Now they are communicating with a group of glands that sit in this mucosa right here, and these glands, these organs of Schultz or receptors of Schultz, are collectively known as the optic glands. So it's not one single gland. Now I'd like to draw a little bit. Let's draw the bulb and the optic tract. I'll use my favorite drawing color, which is yellow, because it's easy to see. I'll make it a little bit bigger than it should be. And as we come back a little bit, I'll color it over. So this is fatter than it would normally be. Right there is going to be the optic nerve. There's the bulb right there. I've got my pen right over it. I'll put a little dot on it so you can see it right here. When I take it away, you'll be able to see it, and I'll put a little dot over the two optic bulbs. Now, coming into the optic tract from the back, just for sake of completion right now, is going to be a lateral stria. Actually, I'll use a different color, something a little easier to see. Let's use red. So a lateral stria over here, an intermediate stria, a medial stria, and then you're also going to have a diagonal band that goes over to the amygdala called the diagonal band of Broca, and then you're also going to have another bifurcation here that goes into the anterior commissure and crosses the midline. So in total, there are 5 of them. Let's go back to a sagittal drawing of the olfactory bulb and tract. We'll go back to my yellow. I'm going to draw right over it. It's a very thin stripe under the gyrus rectus. Then it has a little bulbous configuration. There's your bulb right there, and then it comes back. And now I'm going to blow it up for you. Pardon my drawing skills. And as you know, there are a bunch of tracts coming into it from the back, 5 of them. You've seen them in the axial projection. And now let's pretend we've got some mucosa underneath. A couple words about the olfactory bulb. The olfactory bulb is actually a gray matter mass. It's an evagination of the telencephalon, as stated, located between the gyrus rectus and the cribriform plate. And it contains neurons known as mitral cells. So now let's look at what happens. Our tracts are coming forward into the bulb. And when they get into the bulb, we'll have 3 of them here, they become mitral cells. They pass right through the mitral cells, and we'll make the mitral cells blue. So the mitral cells are right here. Then the next thing that happens is a synapse. So we'll make the synapse something interesting, like some type of weird magenta. So now you have a synapse right there. And then you have continuation with primary sensory axons right into the glands of Schultz in the nasal mucosa. So we'll draw that in maybe green. So it'll perforate the crista galli, go right into the nasal mucosa, and it will pick up these receptors, these glands of Schultz, and we'll make those kind of a weird-looking purple so you can see them. So that's more or less how things go for the olfactory bulb. The dendrites continue in the olfactory tract, which terminates in the region of the trigone. So you've got dendrites right here. You've got axons coming back that I could color them in blue. But right at this locus, now I'm going to take it away, the olfactory trigone, this shelf right here, is the termination location for those axons before they bifurcate into those 5 separate divisions that I described: medial, lateral, intermediate, diagonal band of Broca, and the one going to the anterior commissure. We'll talk about those in a separate vignette. That's the anatomy of the olfactory bulb. Let's talk a little bit about the olfactory tracts, or dendrites, that continue in the tract and terminate in the olfactory trigone and tuberculum in correspondence with the anterior perforated substance, which can be found just anterosuperior to the pituitary gland and fossa. So the perforated substance is going to be right here. The tuberculum is located right here. So I'm going to draw in the olfactory bulb and tract containing its dendrites lying directly over the gyrus rectus, between it and the crista galli. It comes back, and it is going to divide into 5 structures here in a minute. This little sulcus right here is the olfactory sulcus. This is the medial olfactory gyrus. This is the orbitofrontal gyrus, and the sulcus separating them. Now inside are our dendrites. I'm going to make them pink, and as they come back, they're going to split into 5 divisions. One is the lateral olfactory stria, goes off to the side. You see, here's our trigonal area right here, this little shelf. And then another one is going to go obliquely to the amygdala. This is known as the diagonal band of Broca. And I will mark the amygdala as kind of a round, puffy little structure right here. Then a pretty vestigial, small, intermediate stria. We've got a medial stria, medial olfactory stria, and then a little bit higher up, coursing obliquely, merging with the anterior commissure, which we don't see on this particular cut, is the commissural communication of these dendrites. So now, once we've hit the amygdala, something else interesting happens. You've got another group of fibers that crosses over, they're kind of arc-shaped, and they go up towards the thalamus. So I'm going to make the thalamus a different color, even though we're not at the level of the thalamus. Let's make it bright green. So this would be the thalamus, and this portion of the thalamus that is involved in olfaction consists of the stria medullaris thalami, the medial nucleus of the thalamus. You also got a little bit of the hypothalamus involved, the lateral hypothalamus, and right behind it, the habenular commissure is also involved. So these dendrites do reach these structures in the thalamus, and the habenular commissure, which was looking for a function for many years, it is involved in olfaction. So now let's go up a little bit. By the way, here is the here's the perforated substance that lies just anterosuperior to the pituitary gland, a little bit off to the side right here. Should be seen on both sides. Again, here's the perforated substance on the opposite side. And now let's go up to the level of the thalamus. And so in the medial portion of the thalamus is where you're going to have these arc-shaped tracts that came from the amygdala. So you got the diagonal band going this way to the amygdala. Then back over to the thalamus, you're going to have a group of arc-shaped tracts there. And they have various names that maybe isn't so important, like the medial telencephalic fasciculus reaches the thalamus, and then, as we said, the stria medullaris thalami and the medial nucleus of thalamus are located here with the habenula immediately behind it. You can see we're near the pineal gland. Maybe I've drawn it a little bit too big. I won't isolate the habenula right now, but I think you get the picture. So, in summary, you've got dendrites that course laterally, medially. They do cross the midline. And before ending, 2 stria diverge. The lateral stria is connected with the lateral olfactory nucleus, and it's also directed to the amygdaloid body, and the medial olfactory stria is directed to the septal nuclei and hypothalamus. Cortical projections of olfactory function are identified mostly in the prepiriform and the entorhinal cortex. Where's the entorhinal cortex? Right here. Let's go coronally. Let's find your temporal lobe. And there is your entorhinal cortex right there. So that completes our discussion of the olfactory pathway, which includes, by the way, the cingulate gyrus, the sulcus of the corpus callosum, the longitudinal stria of the corpus callosum, and the dentate gyrus, and as stated, the uncus and amygdala. Let's move on, shall we? Pomerantz out. Let's talk about the optic nerve and pathway. Cranial nerve number 2, responsible for vision, an all-important nerve. We start out very simply anteriorly, where we have retinal cells, which we'll define a little bit later in some detail. And then we go right into the optic nerve. And we'll call this the intraorbital portion of the optic nerve. And now we'll scroll a little bit further back to get to the foraminal portion of the nerve. You can just barely see it right there on both sides. So foraminal optic nerve. And then you want to get to the prechiasmatic optic nerve here, then the optic chiasm, and then the optic tract with the pituitary stalk and infundibulum and median eminence located there. So let's go back down to the foraminal nerve and follow it forward again as the intraorbital portion of the optic nerve, and then back to the retina. Now let's go back to the optic chiasm for a minute. The optic chiasm has this funny little hockey stick shape, and these structures continue back to the lateral geniculate nuclei, where they will form a synapse. There's also a synapse in the region of the superior colliculus that they give off. So you have one synapse here, one synapse here. And then you'll have a continuation from the lateral geniculate nucleus as the optic radiation. We're in the temporal zone region now, so we'll call this the temporal knee or temporal portion of the optic radiation. And it kind of makes this little notch right here, and then makes a turn posteriorly towards the occipital lobe. And many of these fibers are going to arborize around the calcarine fissure, which is right here, and here's the corresponding calcarine fissure right there. So I'm going to draw over the calcarine fissure. Here's the parieto-occipital sulcus separating the occipital lobe or cuneus from the precuneus. So I'm going to draw it all in together so you've got it in one fell swoop. You've got the retina here, then you've got the optic nerve, then you've got the intracanalicular foraminal optic nerve, then the prechiasmatic portion of the optic nerve, then you hit the chiasm, which we have right here, then you've got the optic tract that goes back. The optic tract is going to have a synapse with the lateral geniculate nucleus and the superior colliculus. It's going to continue on as the optic radiation. There's going to be an upper and a lower portion of the optic radiation. I've drawn in the temporal portion or temporal knee of the optic radiation. This area is called the sagittal stria of the optic radiation, and then it's going to arborize onto the occipital lobe right around the calcarine sulcus on both sides. So that's a quick intro to the visual pathway. Pomerantz out. I'd like to talk a little bit about the eyeball, including the globe and the retina. Obviously, there's a couple of eyeballs right here. Here they are. And they're secured in part by some extraocular muscles. We're more interested in the optic nerve and the nerves that sit within the orbital cavity. Now, most of these are clustered around the fovea, so there's a higher concentration right around the optic nerve than there is off to the side. So I'd like to make 3 points on this vignette. I want to talk about the layers of the globe, the field orientation of the retina and the retinal projections, and the appearance of retinal and choroidal detachment. So let's start out with the layers. If you look sagittally, you can see a somewhat pigmented, hyper-intense appearance to the back of the optic nerve right here. And this consists of pigmented structures that include rods and cones, especially the cones. And then you've got a few layers, including this darker scleroid layer in the back. And then it's very hard at this resolution to separate out the other layers, which include a choroidal and a retinal layer. Now, the reason that that's important is that in detachments on MRI, the pattern is usually indicative of the type of detachment you have. So if you have a detachment that looks kind of like this, that comes to a V in the back, where the effusions and the hemorrhage is marginated by what we call the ora serrata, and it makes this coalescent V, then it's a retinal detachment. On the other hand, if it goes the other way, if it's convex inward and then sort of makes almost like a column like this but doesn't converge, that's going to be more consistent with a choroidal detachment. Just a little pearl for your perusal and interest. The third point I'd like to make is regarding the fields in the orbit. Now, most people know this from medical school training, but let's make some fields here. We've got a field on the left and a field on the right. Now I'll use something like red to show you the temporal field. There's the temporal field on the patient's left side, and here's the temporal field on the patient's right side. The temporal field, in other words, what you see on the outside, is going to project here and here. So the outer field, pretend this is the outer field here, is going to project to the medial portion of the globe, which is a little bit confusing. Let's pick another color. Let's go with something like light green. On the other hand, the medial field, which would be here, in other words, the outside world, medially, is going to project on the lateral aspect of the globe and the retina. So that's a little bit confusing. So now that it projects on the lateral side, where is it going to come back? It's going to come back to, it's going to come along the optic nerve laterally, and when it gets to the optic chiasm, it's going to stay laterally in the optic chiasm, whereas the medial component, which we'll see in red, is going to stay medially within the optic nerve, and it is going to decussate to the contralateral side, where it'll go to. It'll have that little temporal knee or temporal-occipital knee as the optic radiations, where it'll go to the calcarine cortex. Same thing on this side. This one's going to decussate over to the opposite side and supply the innervation right around the calcarine sulcus right there. So that again is a little bit confusing. So you've got lateral field going to medial retina, going to medial nerve, decussating over to the contralateral optic chiasm, going to the contralateral pericalcarine area in the cortex of the occipital lobe or cuneus. Let's move on, shall we? Pomerantz out. Let's talk about the optic chiasm now, which is kind of H-shaped. Looks a little bit like the letter H right here. I'll draw over it. You've got the prechiasmatic nerve, then in the body of the H, and then the H continues on back as the optic tract. Now, you all know from prior discussions that the lateral projection in the lateral field projects onto the medial aspect of the retina and back of the orbit, then comes back through the optic nerve, and then continues on to the contralateral side. So it goes across, whereas the other projection will stay on the same side. So both medial sides are going to cross over to the opposite optic chiasm, which was discussed in another vignette. Now, as we follow the optic tract back and we go up a little bit higher, right to this locus here, and I'm going to use the color yellow to delimit it. That is the lateral geniculate nucleus right there. And from the lateral geniculate nucleus, where there is a synapse by the chiasm, you can see how close they are, there is also a synapse to the superior colliculi. So you have a synapse this way as well. Now from there, you have continuation of fibers back posteriorly, and I'll use a combination of the color blue and the color red to show you this kind of knee. This is known as the knee of the optic radiation. There's going to be an inferior temporal component and a superior component, and they will supply the cuneus and the region of the calcarine cortex. And here is your calcarine sulcus right here. Anterior to the calcarine sulcus is the superior lingual gyrus right there. Then you've got the sulcus itself. And if we scroll a little bit, immediately behind the sulcus is a little small nubbin of a gyrus known as the descendens gyrus of Eckler. If you look in the sagittal projection, pretty easy to identify the calcarine sulcus. It's the main sulcus right here that merges with the parietal occipital sulcus, forming this Y, or as Tom Nadich has described it, the lazy Y that continues on anteriorly as the anterior calcarine sulcus. Right above it, you have this little beef tongue of the cingulum coming around just above it. So that's the anatomy of the visual pathway in its retrochiasmatic distribution. We talked a little bit about some of the radiations and arborizations of the field and how the nerves transmit posteriorly. We'll talk more about this when we get into functional anatomy at a later date. Pomerantz out. Let's finish our discussion of cranial nerve number 2, the optic nerve, with a couple of pearls. The contralateral nasal retinal projection from the lateral projecting onto the medial aspect of the retina, so lateral projecting on medial retina, is going to come down and is going to cross over the other side. Same thing here. Projects onto the medial retina, comes down, and crosses in the optic chiasm to the contralateral side. In contrast, the medial field is going to project onto the lateral retina, and it's going to stay ipsilateral, like so. Now, we also said that there are a number of synapses, which we'll show you in a minute. There is a knee or turn of the optic radiation. There's an occipital or occipitotemporal and a temporal component of this turn, where it will then project onto the cuneus or optic cortex. It'll happen on both sides. Now I'm going to scroll up a little bit to the level of the calcarine sulcus, and at this level we've got the calcarine cortex, and I wanted to highlight the synapse positions a little bit higher, which include the lateral geniculate nucleus, which is going to sit right about here on both sides. that's going to receive a synapse. The superior colliculus, that's going to receive a synapse. And now we have one final third synapse to add to our layering of anatomy for the visual pathway, and that is the pulvinar right there. So that concludes our discussion of the visual pathway. So if we put it all together, we've got the globes, we've got the retina, we've got the optic nerve, we've got the intracanalicular foraminal optic nerve, we have the prechiasmatic nerve, the optic chiasm, a little infundibular recess in the middle with a pituitary stalk, the optic tracts moving posteriorly, a synapse on the superior colliculus and the lateral geniculate nucleus, a synapse on the pulvinar, and then continuation back, including something known as Meyer's loop that will arborize onto the visual cortex in the region of the calcarine sulcus, which we see right here. That concludes our discussion of the visual pathway. Let's talk about the third nerve. The cranial nerves are pretty small, and that's why we have 3D, 1 millimeter or sub 1 millimeter slice thickness that we have reformatted from the axial into the coronal projection. And rather than using the reformat, I've put up the sagittal 3D flare, which shows the apparent exit of the third nerve from the interpeduncular cistern in the midbrain. You can see it quite well on the flare, bathed by dark signal intensity fluid. If only it were always that easy, and it is when you have thin section imaging. Now in the axial projection, let's start out by drawing the real origin of the oculomotor nerve, which is here and here. The oculomotor nerve comes off the third nerve nucleus and the adjacent Edinger-Westphal nucleus. Now I'm not so much interested in you learning about the intramedullary origin of the nerve at this point, but I do want you to know that the third nerve has an exit in the midbrain. So it is coursing through the midbrain, and then it comes out in the interpeduncular cistern, and it's a little hard to see as it exits. You can see it right there. I'm drawing over it right now, and I'm drawing over it again on the right side. But look at the long intramedullary, intraaxial course in the brainstem of the third nerve. That is why the third nerve is so susceptible to compression in the midbrain, because it has a long longitudinal axis. Now I'm going to take my arrows away, or take my lines away, my orange lines away, and you can follow the third nerve as it continues onward. And its next stopping point is going to be the sulcus of the oculomotor nerve before it enters, as one of the larger nerves, the cavernous sinus. So it goes interpeduncular cistern, oculomotor sulcus, and then into the cavernous sinus, where it then finds its way into the superior orbital fissure. Now, if we talk about the apparent origin of the oculomotor nerve, I'm talking about where the nerve comes out of the brainstem itself. When I'm talking about the real origin, I'm talking about where it starts out in the nuclei of the brainstem, namely in this case, the midbrain. Now you can also see the third nerve in the coronal projection. An easy way to do it is just to cross-reference it. Here it is as a tiny little dot. Now the third nerve comes out between the posterior cerebral artery. You can see the arc of the posterior cerebral artery on the right. It's a little harder to see on the left. It's right there. But right underneath it is the third nerve. So the third nerve is going to come out between the PCA, posterior cerebral artery, and the not so well seen superior cerebellar artery. You can see a wisp of it here on the right, but not so much on the left. This is important because aneurysms in this locus can produce paresis of the third nerve, or so-called third nerve palsy. So I want to give you some tips for isolating the third nerve. One tip is that you've got to have high image quality or high spatial resolution. So thin section imaging is vital to identifying any cranial nerve, and I like to see something on the order of 1.5 millimeters or less. You can then go hit the reconstruction button and cross-reference in the coronal or in the sagittal projection. We have reconstructed in the coronal projection. Our sagittal is a separate flare. Now, one clue for finding the third nerve is just find the interpeduncular cistern. Simple. Once you find that cistern, you work your way out and you look for a gray signal intensity structure. And you follow it, and you make sure that it exhibits no flow void, because otherwise it's a vessel, and no slow flow phenomenon. In other words, it shouldn't be bright white and it shouldn't be black. It should be gray. and it should course in the right distribution, which this one does. It goes into the oculomotor sulcus, then into the cavernous sinus, and then into the superior orbital fissure. So that's pretty easy. Another tip off to finding it is to locate the posterior cerebral artery. Now, we said in our first vignette that masses around the posterior cerebral artery or the superior cerebellar artery can compress the third nerve. But the classic compression of the third nerve as an aneurysm comes from the PCOM, which you all know is a more common aneurysm than any of these two other arteries. So PCOM aneurysms will be in close apposition to the third nerve and may produce a third nerve palsy. But once you find the PCA, you'll know that the third nerve is going to be right nearby, and it is. Now, in the coronal projection, all you got to do is find and cross-reference the third nerve with the third nerve in the axial projection. So you have to be able to locate it in the axial projection, which is easier. Then I like to follow the third nerve back towards the midbrain. Another way to locate the third nerve, if you're spot localizing it in the coronal projection, is to go down and to the side of the mammillary body. So there are the two mammillary bodies. Down and to the side, there's your third nerve on the left. There is your third nerve on the right. Now let's come forward. Now that looks like initially a vessel. There's a vessel right next to it, but it's not. You continue to follow it. It's gray. It exhibits no flow phenomenon, no flow void. We keep following it, following it, following it. And what are we next to? We are next to the uncus. So uncal herniation will produce a third nerve palsy right there. We are in the oculomotor sulcus now as we move forward, and now we've entered the upper portion of the cavernous sinus. I'm just showing you the nerve on the patient's left as we continue to move forward. In the sagittal projection, we already showed you the third nerve, which is probably the easiest projection to see it. Thin section imaging shows you the nerve in the interpeduncular cistern. One last caveat. What does the third nerve innervate? It innervates all the extraocular muscles except for two. The lateral rectus, which is innervated by the sixth, and the superior oblique, which is innervated by the fourth. And finally, the additional supply of the third nerve is the levator of the upper eyelid, as well as the annular fibers of the ciliary muscle and the sphincter muscles of the pupil, parasympathetic innervation. That concludes our discussion of the third nerve. We'll talk about third nerve syndromes when we get into cranial nerve pathology. Pomerantz out. I want to talk about the real origin of the third cranial nerve. Not the origin where it comes out of the brainstem, but the origin of the nuclei in the brainstem. Now, I alluded to this in Vignette 1, but I want to get a little more detailed now. So I'm going to draw. If I find my aqueduct of Sylvius, my third nerve nucleus and my accessory third nerve nucleus is going to be closer to the aqueduct of Sylvius, right in front of the periaqueductal gray, than the fourth nerve nucleus, which is a little farther anteriorly and a little further caught at. I gave you some tricks to find it. So this nucleus closer to the aqueduct of Sylvius, and then if we turn our attention to the T2 weighted image, where we can see the red nucleus right here and here. In fact, I'm going to make them red just for giggles. So one red on the right, one red on the left. Now I'm going to take my orange-colored oculomotor nerve, or third nerve, and I'm going to watch it come out, and it bows a little bit. It almost bisects the red nucleus. Now, there are root filaments that contribute a little bit out to the side here, so you can get pathology on the lateral margin of the red nucleus that affects the oculomotor apparatus. But the main nerve takes a pretty long course intramedullary through the brainstem at the level of the superior colliculus, all of this being intramedullary and not easily visualized, certainly not visualized by the surgeon, and then the nerve comes out in the intrapeduncular cistern where it exits, headed for the oculomotor sulcus. There are two small dots representing the third nerve sitting directly behind the mammillary bodies. Now, a couple of other salient points. When the third nerve comes out, as it exits in the interpeduncular cistern, it's mesial or medial to the substantia nigra. So it's not going to come out over here. It may look like it does due to volume averaging, but it's going to come out always medial to the substantia nigra. So that's another trick for locating its apparent exit from the midbrain. In the next vignette, I want to talk a little bit about what can happen to the third nerve and various syndromes in the medullary space of the midbrain, like Weber syndrome. Let's move on, shall we? I want to make 3 points about third nerve syndromes. First, every medical student and resident, fellow, and attending should know that PCOM aneurysms can generate a third nerve palsy, and that's the classic aneurysm to do so. Second, intranuclear ophthalmoplegia. Let's redraw the third nerve nucleus, which sits right in front of the aqueduct of Sylvius. There's also an accessory third nerve nucleus that's a little medial. And then the nerve kind of bows outward a little bit and exits the interpeduncular cistern medial to the substantia nigra, which is right over here. And you can actually see a little bit of the third nerve, these little gray dots right there. Now, in intranuclear ophthalmoplegia, you'll have involvement of the nucleus itself and the medial longitudinal fasciculus, perhaps as an MS plaque. So an MS plaque might be located right over here. It might clip one or both of the nuclei, and you would get an INO, an intranuclear ophthalmoplegia. What's that look like? Well, we're going to make a couple of eyes. Here's an eyeball. Here's another eyeball. And then we're going to have the patient look to their left. And when they look to their left, the lateral rectus pulls this eyeball over. But because there's a third nerve palsy, and I actually should make the palsy over here, so let's make the lesion right there. Not on this side. I'm going to erase it, so it's going to be on the right side. And this eyeball is lagging because the third nerve is weak. Therefore, the medial rectus can't pull the eyeball over, but the lateral rectus does because it's functioning. And so this eye has an adduction problem, and we say this patient has a right INO. The third point I want to make is related to Weber's syndrome. So let me draw again the third nerve. Here's the third nerve nucleus. Here's the third nerve, bows out a little bit, then comes in. And in Weber's syndrome, let's go to my favorite color, yellow. We're going to have an area along the medial peduncle that clips the third nerve as it courses towards its apparent exit. So right there, it's going to get clipped, and the patient is going to have an ipsilateral third nerve palsy with a fixed pupil. What else are they going to have? Well, let's look over here. Let's draw it again. And we relatively spare the red nucleus in Weber's syndrome, but we do involve the exiting, as you can see over here, the exiting third nerve. So ipsilateral third nerve palsy. You may also have a supranuclear seventh nerve ipsilateral palsy, but because the corticospinal tract is going to decussate as internal arcuate fibers, it's going to be a spastic hemiparesis that's contralateral. So contralateral motor plus ipsilateral 7 plus ipsilateral third is going to give you a Weber's syndrome. And every medical student absolutely has to learn this. What produces it? Occlusion of the posterior cerebral artery, the PCOM, or posterior choroidal branches. There's a variation of this called Bendix's syndrome, where it comes back a little further, and it may get the red nucleus. It may also get the cross-descending superior cerebellar peduncle, but the bottom line, more advanced, not so basic, is that you have an ipsilateral oculomotor nerve with a contralateral cerebellar syndrome. That's known as Bendix syndrome. As we finish out, let's give some creds to the Weber family. The father, Hermann David Weber, described this Weber's vascular syndrome. The son, Frederick Parks Weber, described Klippel-Trenaunay Weber. Parks-Weber syndrome, Osler-Weber-Rondeau, a prolific family. That's all from me. Pomerantz out. I want to talk to you about the trochlear nerve, the fourth cranial nerve. The true origin of the nerve is in the midbrain at the level of the inferior colliculus, just above the frenulum of the superior medullary velum. Now, one tip-off to isolating it is to find the aqueduct of Sylvius, go anterior, and then about 5 millimeters over. So about 7 to 8 millimeters anterior, about 5 millimeters over, and this dark line, which represents the posterior longitudinal fasciculus, right behind it and medial to it is going to be the trochlear nucleus. So I'm going to make a little dot for the trochlear nucleus. Here's the paired one on the contralateral side. Don't see the posterior longitudinal fasciculus quite as well as we do on the patient's left side, your right. And then the trochlear nerve comes out and it decussates in the back in the intercollicular region of the inferior colliculus, just above. It sags down a little bit and crisscrosses right above the frenulum of the superior medullary velum. These little dots right here represent the trochlear nerve. It's a little hard to see in the coronal projection, and I'm not yet going to try and isolate it. Now, after it gets out and crisscrosses, I'm going to take my dots away. So let's take them away. There are the trochlear nerves. They've already decussated. And you can see a little bit of the trochlear nerve on the left, a little volume averaging on the right. Now I'm going to come back again and take its course, the so-called interpeduncular course. So it's come out, it's decussated in the back, and now it's going to come around in its interpeduncular course around the midbrain. And then we'll go on the right side this time, an equal opportunity sided display. We're going to come through the cavernous sinus and into the superior orbital fissure on our way to the superior oblique muscle and its pulley, which it innervates. Now, in the sagittal projection, we've isolated the trochlear nerve right there. Let's try and isolate it in the coronal projection. It's a little difficult because it is absolutely the thinnest nerve. And right there, this dot right here, is the right-sided trochlear nerve. Now, for you residents and fellows and medical students out there, it is the only one to exit posteriorly, the only cranial nerve. It is also the only cranial nerve to decussate intracranially. It enters the posterior superior orbital fissure outside the tendinous ring, and as stated, it supplies the superior oblique muscle of the orbit. Let's move on, shall we? Pomerantz out. I want to give you some tricks to isolate the fourth nerve and the fourth nerve nucleus. If you find the aqueduct of Sylvius in the inferior midbrain, you go forward 7 millimeters and over 5 millimeters along the inner edge of this dark line, the posterior longitudinal fasciculus. You are going to run into the trochlear nucleus on the left, and then there's a paired one on the opposite side. Now, the trochlear nerve is going to come back and arc around the periaqueductal gray, and it's going to decussate. I'm not going to show the decussation because I want you to see the decussated trochlear nerves right there. So another trick to finding the nerve is find the inferior colliculus. There's the inferior colliculus. There is the frenulum of the superior medullary velum right there. And I'm going to scroll a little bit now and take my lines away. I'm going to do some scrolling for you. There's the frenulum of the superior medullary velum, and right there is the inferior colliculus, and there is the trochlear nerve. You're seeing some wispy, spidery structures here, but the one that is most round right there is the trochlear nerve itself. Now, another trick is to find the third nerve. So let's cross-reference the third nerve in the interpeduncular cistern right there. There's your third nerve on the patient's right. There's the third nerve on the left. Now let's keep going forward. There's the third nerve. Keep following it. Keep following. We're not able to see the fourth nerve. Keep going. Keep going. The nerve is now entering the oculomotor sulcus. The nerve has now entered the cavernous sinus. There's the carotid artery. And what's the first thing below it? This little gray structure right there. I'm going to put a dot on top of it. That is the fourth nerve right there. What types of pathology affect the fourth nerve? Well, the fourth nerve supplies the superior oblique muscle of the eyeball. So one of the syndromes that affects the superior oblique muscle is Brown syndrome, which is a contraction or scar of the pulley of the superior oblique muscle. That can actually compress and encase the fourth nerve and contribute to end cranial nerve encroachment on that nerve in what's known as Brown's syndrome, or the fibrotic syndrome of the superior oblique pulley. Let's move on, shall we? I'm here to talk to you about the fifth nerve or trigeminal nerve. Now, I could start in the brain stem with the real origin of the nerve, but that might drive you crazy because it's so complex. So I'm going to begin with the exterior exit of the nerve from the inferior aspect of the pons. You've got the nerve, which consists of a sensory and motor portion, then a ganglion, and then 3 major divisions. Now, the lingual nerve, well, it took a swerve around the hyoglossus. "Well, I'll be plucked," said Wharton's duct. "The lingual nerve has crossed us." That's one mnemonic for one branch of one division of the 3 divisions of the trigeminal nerve. Thus, you see the challenge. The trigeminal nerve, well, it's a mixed nerve. Its sensory, portio major portion carries touch, nociception, temperature, proprioception from the face, the facial, the masticator muscles, the TMJ, and the intraoral cavity. Somatosensory fibers of the trigeminal nerve enter the pons in the sensory root known as the portio major. They're distributed to a principal sensory nucleus and the spinal trigeminal nucleus. Fibers from the principal sensory nucleus and from the pars oralis and interpolaris of the spinal nucleus of the trigeminal nerve, which we'll show you, decussate at the level of the pons and join the medial lemniscus, which is an important proprioceptive pathway, as something known as the trigeminal lemniscus, and it terminates on the medial VPM, or ventral posterior nucleus of the thalamus. There's also some uncrossed fibers, but the bottom line is you've got some fibers going over to the VPM on one side, you've got some fibers going over to the VPM, the ventral posterior nucleus of the thalamus, on the other side, so you've got projections to both sides. And then on both sides, they go up to S1, the primary somatosensory cortex of the brain. That's a lot of information, but we're going to drill into it a little more deeply on subsequent vignettes. Dr. P out. Dr. P back with the dreaded trigeminal nerve. It's the biggest of the cranial nerves, and somatosensory fibers of the trigeminal nerve enter the pons in the sensory root known as the portio major. It's the main root, even though it's sensory, and it's distributed to the principal sensory nucleus and spinal trigeminal nucleus. So let's take a look at those. This gets a little bit scary. I'm going to do some very rudimentary, but I think helpful drawing. I'm going to have you look at sort of an AP projection. I'm going to make a thalamus on one side and a thalamus on the other side. It'll have a nucleus in there in a second. Then we're going to come down from the thalamus, midbrain and cerebral peduncles. Then we'll get ourselves a little bit of a bump at the level of the pons. Then on this side, I'm going to draw in the forked or triforked entrance of the portio major, the sensory division of the trigeminal nerve. I'm also going to draw in a little bit smaller the motor portion of the trigeminal nerve. Then the bump continues on down a little bit and then starts to taper in as the medulla and as the spine. It's a little asymmetric, but that's okay. My drawing skills require a little bit of improvement. So now I'm going to change colors a little bit just to show you how things are and where they are. I'm going to start up here in the region of the thalamus, and I'm going to highlight an important structure, the ventral posteromedial nucleus of thalamus, which is where the trigeminal system is going to end up. From here, fibers are going to go to the postcentral gyrus, which is the sensory gyrus, and they will arborize on the surface that's right above the temporal operculum. And I think that's a story for another day. Now, as we go down, let's go down on this side. We've got a series of fibers that come down, and they reach the principal sensory nucleus of the trigeminal nerve right about here, and it's a little bit posterior in its position, even though this is an AP projection. If we were in cross-section, you could appreciate that. And so these fibers are coming in from the portio major. Now I'll make them blue, give them a little bit of highlight. They come into the primary sensory nucleus of the trigeminal nerve in the posterolateral aspect of the pons. Now, right below this is the second important nuclear structure, which is the spinal trigeminal nucleus. I'm going to make that a little bit like a cone head. You remember the show from Saturday Night Live. There's the cone at the top. And then as we come down, this goes for quite a distance, and then eventually it transitions into two other tracts, but I'm going to divide this one up into thirds, and the name of these thirds are the Pars Oralis, O, the second one is the Pars Interpolaris, I, and the third one is the Pars Caudalis, C. So that's a little bit confusing, all part of this spinal trigeminal nucleus that gets into the spinal canal and then divvies up, time for a new color, divvies up into, let's pick something that the audience might like, something a little brighter, divvies up into two tracts right here that are going to be seen in the posterolateral aspect of the spine, and these are known as the nucleus proprius and the substantia gelatinosa together. So we're going to ignore these right now. I just want you to be aware of them. But for the portio major, coming in through the posterolateral pons, there is a synapse and connection to the principal nucleus, and there are multiple connections. Let's go back to blue. Multiple connections to the pars oralis, the pars interpolaris, and the pars caudalis. Now you might say, well, what about the poor, little, teeny, weeny, oft-forgotten motor portion of the trigeminal nerve? Well, it has something that's a little bit smaller and weenier and teenier to go to. And this is going to sit a little medial, and it's going to be quite a bit thinner than the principal nucleus. Goes up a little further in the upper pons and reaches portions into the midbrain, and this is known as the trigeminal mesencephalic nucleus of 5. Then you've got another structure called the motor nucleus, and it sits right underneath, directly adjacent to the principal sensory nucleus. So you've got principal sensory here in blue, principal motor here in green, and then trigeminal mesencephalic nucleus of 5 going up like that. And what goes there? Well, the motor portion, the portio minor of the trigeminal nerve, is going to have synapse connections to this component and to the primary motor nucleus, namely this component. So this over here is going to sit posterolateral in the pons. This is going to sit quite a bit higher and slightly more medial to the other structures. So again, motor medial, motor midbrain, sensory lower in the pons, and that's the one you really want to remember. Dr. P out. Dr. P here. I want to take you through an axial flare, thin section T1 and fast spin echo T2, describing for you the nuclear anatomy and position of the trigeminal system as it relates to the brainstem and the brainstem parenchyma. So I have intentionally begun at a level where you can see the portio major of the trigeminal nerve. There is Meckel's cave to which it will go. You can see the portio minor, the motor component, going towards Meckel's cave. And Meckel's cave is going to sit a little bit more anterosuperior. And then as the nerves come back, they come back a little bit more postero-inferior with only a slight obliquity. There's the apparent origin of the portio major, the sensory component of the trigeminal nerve. Now let's show you where it goes. I'm going to go down one cut, just a little bit, and I'm going to go posterolateral. So I'm anterolateral to the fourth ventricle, but I'm in the posterolateral aspect of the pons relative to the midline. So somewhere about here, we're going to be in the region of the principal sensory nucleus of 5. Then immediately underneath that is going to be the spinal trigeminal nucleus. So if we were to have a coronal section, right under this round structure would be a cone head consisting of the pars oralis, interpolaris, and caudalis. And so we'd have a synapse here in the principal nucleus, and then one on each of these as they descend towards the spine, eventually reaching the nucleus proprius and substantia gelatinosa in the spine. Now what's coming here? I'm going to take away my color marks for a second. What's coming here is the sensory division of 5. What about the more thin, wispy, more medially positioned motor division of 5, the portio minor? Where does it go? Well, we already showed you the sensory component. Let's draw that back in again. Kind of right about here. And where are we going to find the motor, the principal motor nucleus? We're going to find it a little more mesial to this location. It's also going to be smaller in size. And then right on top of that, in the coronal projection, just slightly inside it. So if we were to say in the coronal projection, just for imagination's sake, here's the principal motor nucleus of 5. Just above that is another little cone head, but a lot smaller than that. And this is going to represent the trigeminal mesencephalic nucleus of 5. And the portio minor is going to send synapse fibers to the trigeminal and mesencephalic nucleus of 5, which is going to be over here, and then to the principal motor nucleus, which is going to be right there as a round green structure. And then as we scroll up and down, you can just get an idea of where these things would exist relative to the antero-posterior orientation and cranio-caudate orientation, even in the medulla. And when you get down in the pons, you're going to be somewhat posterolateral near the substantia gelatinosa and the nucleus proprius. And right next to those, and right above those actually, are going to be some of those descending fibers of sensation that we described, namely the pars caudalis of the spinal sensory nucleus. Let's move on. That was tough. Dr. P out. Dr. P here talking about the ganglia of the head and neck, and I want to focus on the parasympathetic ganglia. There are 4 of them in the head and neck. 2 of them are visible here, the pterygopalatine ganglion, also known as Meckel's ganglion, the nasal ganglion, and the sphenopalatine ganglion. Then we've got this one below, the submandibular ganglion, an important one, and 2 that do not appear in this classic drawing from Gray's Anatomy, the ciliary ganglion, which controls the sphincter papillae of the sympathetic nervous system via V1, and parasympathetics via the 3rd nerve. Then we've got the otic ganglion. That's the one that's kind of oft overlooked. It's located inside the mandibular condyle. Really hard to kind of place it right here, but I'll just kind of put it in this region. It's not an exact placement, but just to talk about its function, it's associated with the tensor tympani and tensor veli palatini with parasympathetic function via nerves 7 and 9. Then we get into the 2 that we're most interested in that are drawn in here again, the pterygopalatine ganglion and the maxillary ganglion. The pterygopalatine ganglion supplies the lacrimal and the nasal cavity via the 5th nerve and the Vidian nerve. We'll talk a little bit more about it in a second. And the submandibular ganglion provides secretory function to the submandibular glands and the sublingual glands, but receives quite a bit of information and support from the chorda tympani from the 7th nerve. So now let's have a look on MRI of our parasympathetic ganglia and their association or lack thereof with cranial nerve 5 in the head and neck. Dr. P here, back with the parasympathetic ganglia and their relationship to cranial nerve 5. There are 4 of them in the head and neck, the ciliary, the pterygopalatine, the submandibular, and the otic. I want to look at an axial T1 thin section 1 millimeter high resolution MRI to show you the position of the 2 that are most important and intimate with the 5th nerve. I want to share with you the position of the submandibular ganglion and pterygopalatine ganglion. Let's start with the SMG first. We're just atop the region of the submandibular gland. It's pretty hard to see on this T1 weighted image, but let's scroll a little bit. And we see this ill-defined sort of stellate round structure that lies just lateral to the hyoglossus, or right near or on top of the hyoglossus, but along the posterior margin of the mylohyoid. That's an important landmark. Now, when we look at this ganglion sagittally, if we were looking from the side, we might see something like the lingual nerve coming down, and by the way, the lingual nerve often houses with its traveling partner, the chordotympany nerve, which is a branch of 7. So lingual nerve from the mandibular division of 5. It has the lingual nerve as its branch, and these two travel together in concert. The branch of the 7th nerve, namely the chordotympany nerve, traveling with, in yellow, the lingual nerve. Now, hanging down from the lingual nerve is the stellate ganglion, is the submandibular ganglion, not the stellate ganglion. So there's your submandibular ganglion, and there are actually two filaments. There's an anterior filament and a posterior filament that suspends this nerve. Now let's talk a little bit more about the function of the nerve. Even though we're talking parasympathetic ganglia in the head and neck, ciliary, pterygopalatine, submandibular, and otic, this particular nerve has some sympathetic function from the external carotid plexus that travels there or gets there via the facial artery. We've got preganglionic parasympathetics from the superior salivary nucleus of the pons via the chordotympany, so they get there via this traveling partner of the chordotympany and the lingual nerve. You've also got some postganglionic sympathetics to the oral area and to the submandibular gland and sublingual gland, where some secretory function is also provided, and there's some sympathetic function in this distribution as well. Now I'd like to move on to, on MRI, the pterygopalatine ganglion. Let's do that, shall we? Dr. P out. Dr. P here talking about the ganglia of the head and neck, the parasympathetics, their relationship to cranial nerve 5. There are 4 of them: ciliary, pterygopalatine, submandibular, and otic. Remember, with the mnemonic COPS, C-O-P-S. We're down here at the floor of the mouth and working our way up. We've got some tongue, and then we get to the region of the palate, the hard and soft palate, and this is the hard palate here. As soon as we get to the maxillary sinus, now we're looking for the optic nerve. So let's go there as an important landmark, the optic foramen. And now let's work our way back down from the optic foramen, where we get into the inferior orbital fissure right there. And the inferior orbital fissure is going to transition into the pterygomaxillary fissure, the pterygopalatine space. And in the upper third of this little fat-filled space right here, behind the maxillary sinus, as we've scrolled from up, or craniad, the inferior orbital fissure, to down, we've reached this important landmark where the pterygopalatine ganglion will live, also known as Meckel's ganglion, the nasal ganglion, and the sphenopalatine ganglion, lying in a little fossa or pocket known as the pterygopalatine fossa. Now, this ganglion has multiple functions. The greater petrosal nerve, a branch of the 7th, has an important role here, as does the maxillary nerve, which provides sensory supply to the lacrimal region and to the nasal cavity. The parasympathetics get there via the nervus intermedius, which is part of the 7th nerve, but in actuality, the supply comes down through the chordotympany nerve, which you've learned in prior vignettes runs in parallel with its traveling partner, the lingual nerve, which is a branch of 5. So this is the location behind more or less the upper border of the maxillary sinus. These 2 layers of fat represent bone marrow. This is the little fossa right here. The ganglion is located in this region. We can blow it up a little bit so you can see. It's a horizontal coursing space that then will exit antero-suprolateral into the inferior orbital fissure, and there are other important connections that we'll dive into more deeply in other vignettes. Dr. P out. Dr. P here talking about the first division of the portio major of the trigeminal nerve, the sensory division. The first branch of the sensory division, also known as the ophthalmic division, is seen right here, labeled number 1. Behind it is the Gasserian or semilunar ganglion and the portio major coming into it. As we go a little bit distally, we'll run into the ciliary ganglion. The ciliary ganglion is associated with sympathetic function of the sphincter pupillae, and parasympathetic function as well via the third cranial nerve. Then we've got the sensory function or nerves to the anterior and posterior ethmoidal areas, which are kind of in this location. The frontal nerve, which is not displayed, but which flips up a little bit above the eyebrow. The nasociliary nerve, as well as the lacrimal nerve, which goes towards the region of the lacrimal bed. So that's the first division of the trigeminal nerve. For you test takers, it's going to go through the SOF, or superior orbital fissure. Don't forget that. Dr. P out. Dr. P here talking to you about the second division of the trigeminal nerve, also known as the maxillary nerve. And here we've got maxillary and number 2 to delimit this nomenclature. This nerve comes off the Gasserian or semilunar ganglion, but runs in an antero-posterior direction through, for you test takers, the foramen rotundum, which, by the way, runs parallel to the Vidian canal, although the maxillary nerve goes through the rotundum, not the Vidian canal. Now, the main ganglion coming off this nerve, which is the most common nerve afflicted in tic douloureux or trigeminal neuralgia, whereas the ophthalmic is the least commonly affected. The pterygopalatine ganglion is seen right here, coming off the maxillary. There's also sensory supply to the pterygopalatine nerve, the zygomatic nerve, the infraorbital nerve, the lacrimal communicating nerve, zygomatic facial and temporal nerves. And we've already discussed the importance and role of the pterygopalatine ganglion, which we said has both sympathetic, sensory, and parasympathetic function. Let's move on to the third division of the trigeminal nerve, the mandibular division. Dr. P out. Dr. P here talking about the mandibular division or third division of the trigeminal nerve, the one that's affected intermediately, in other words, not the most, that's the maxillary division, and not the least, that's the ophthalmic division, but somewhere in between is it affected in trigeminal neuralgia or tic douloureux. It has an up and down orientation, as we see right here, and it exits the brain via the foramen ovale, which may also have running through it some branches of the middle meningeal artery. What else comes off the mandibular division of the fifth nerve? Well, you've got the auriculotemporal nerve. You've got a couple of ganglia, one I don't have drawn in here, the otic ganglion. I'm not going to try and position. I'll just put it in here for effect. You've got another ganglion down here, the submandibular ganglion, which we describe in its own vignette. You've got the deep temporal nerve, the lateral and middle pterygoid nerves. And then you've got the chorda tympani, which is a branch of the seventh nerve, and it travels with its traveling partner, the lingual nerve. So here's the lingual nerve, labeled lingual nerve. Right behind it, that small little nerve, which is a division of 7, right? There it is coming down, came from 7 and blended in with the lingual nerve, traveling as its buddy or partner, is the chorda tympani nerve. The chorda tympani nerve is going to settle right at the submandibular ganglion. There are also some lingual branches of the mandibular nerve. An important branch of the third division of the trigeminal nerve is the inferior alveolar nerve, and when we get into head and neck discussions, we'll spend a lot of time talking about the course and location, especially as it relates to dentistry for the inferior alveolar nerve. Dr. P out. I want to talk to you about the sixth nerve, also known as the abducens nerve. I'm going to start out with a gross anatomic picture of the brainstem. And even though the abducens nerve comes out on the ventral side of the brainstem, I'm starting on the dorsal side for a good reason. We've got some gross anatomic structures here, like the middle cerebellar peduncle, a great landmark. This is a purely afferent structure connecting the brainstem with the cerebellum, but just medial to it is this bump with the dorsal median sulcus. And the bump, which is pretty elongated, is known as the facial colliculus bump. What sits under that colliculus? The facial nerve nucleus, the genu of the facial nerve, and the abducens nerve nucleus, which sits slightly dorsal to it. But they both lie directly underneath this facial colliculus bump at about this level, the inferior aspect of the pons, near the ponto-midbrain junction at the level of the middle cerebellar peduncle. Now, let's flip it over. Let's go over to the ventral side where we've got this big, fat, stuffy belly of the pons, rather plump. And on each side we see the middle cerebellar peduncles, the pontomedullary sulcus from which the sixth nerve will exit. This is known as the apparent exit of the sixth nerve, the apparent origin of the sixth nerve, because the true origin of the sixth nerve lies underneath that facial colliculus bump. Now, when the sixth nerve comes out, it's going to come out lateral to the pyramid. So here are the two pyramids. This is the medulla oblongata. Here's the anteromedian sulcus. So your sixth nerve is going to come out right about here. Pontomedullary sulcus, lateral to the pyramid. Now, sometimes you'll see little linear structures coming out of here, but they light up with contrast, and these are small perforating vessels of the pontine circulation. Don't confuse those with the sixth nerve. So a very important landmark, lateral to the pyramid, is identification of the apparent exit of the sixth nerve. Now, before I show you some sixth nerve anatomy on MRI, let's just do a quick review of what we've covered so far on the cranial nerves. We talked about the olfactory nerve, cranial nerve number 1. We've got an olfactory bulb, and then as it comes back, we don't show it here, it divides up into 3 or 4 different segments, which are outlined in the olfactory section. Then we get into the optic nerve. The optic nerve starts at the level of the retina. You've got photoreceptors in the retina, just like you have receptors in the ethmoid sinus mucosa for the olfactory nerve. And then it comes back as the intracanalicular nerve, the optic nerve, the chiasm, the optic tract, and then goes on to the lateral geniculate nucleus. It has a synapse at the superior colliculus, the stria generi, the calcarine cortex. It also has a pulmonaric synapse. So that's a quick review of the second cranial nerve, which some consider an extension of the brain with arachnoid around it and a subarachnoid space, which you'll be able to see. Then we said the third nerve. What characterizes the third nerve is its exit in the interpeduncular cistern. And then we described its course into the oculomotor sulcus, then into the cavernous sinus, and then on into the orbit where it services the extraocular muscles, all of them except for the superior oblique and the lateral rectus. Then we get into the fifth nerve. Very complex, but the fifth nerve is mostly composed of a portio major, which is sensory, with 3 branches, an ophthalmic, a maxillary, and a mandibular. There's also a portio minor, which is motor, and we'll describe in the fifth nerve section, if you go back to it, the different structures that are innervated by it. Then the characteristics of the trochlear nerve, the fourth nerve, the one before it, are the following. It is the one nerve that comes out in the back, dorsally in the brainstem, and then decussates in the back, and then we're back up to the sixth nerve, which comes out at the pontomedullary sulcus ventrally. Remember the trochlear nerve, dorsally, and it starts out lateral. Its apparent exit is lateral to the pyramid of the pons. Very critical, so you don't confuse it with pontine perforators. Now let's take a look on MRI. So I've got a T1 contrast 1.2 millimeter image on your left, a T2 spin echo, slightly lower resolution, 5 millimeters of slice thickness on the right. Now my purpose in showing you the T2 weighted axial image is to simply draw the real origin of the abducens nucleus. So let's do that. We've got our facial colliculus bump right here, and just deep to that bump, a little more dorsally, we're going to have the abducens nerve nucleus. And since I love blue, I'm going to draw it in blue. Whoops. Since I love blue, I'm going to draw it in blue if I can. And now I can. And then the abducens nerve nucleus is going to take a pretty mesial course before it then sweeps out laterally with its apparent exit from the brainstem at the pontomedullary sulcus. Remember, it's going to come out lateral to the pyramid. It's got a pretty long course through the brainstem. Now, what about the facial nerve nucleus? Because this is called the facial colliculus bump. Let's draw that in orange. Here's my orange. And it's going to sit a little more anterior and slightly lateral to the abducens nerve nucleus. But then the nerve comes out more obliquely, as you would expect, because that's where the facial nerve goes, into the 7th and 8th nerve canal. So that's a pretty important distinction. And either of these nerves can get hit with pathology in this region, including involvement of the medial longitudinal fasciculus and periaqueductal gray, as in multiple sclerosis with plaques affecting these nuclei. Now let's direct your attention over to the left side. We've got an axial, very thin section, T1, C plus image, and there's a reason why I put the C plus image up, because that looks like the 6th nerve coming out of the pontomedullary sulcus, but it enhances. So is it an iridic 6th nerve? No, the 6th nerve was normal. It's not an iridic. It's a small perforator. And how do we know that? Let's look on this side. Lateral to the pyramid, there is a bland gray structure with an oblique course, not going to the 7th and 8th nerve canal, but let's see where it goes. Let's take away our color, and let's follow it. Back to its apparent exit. Now let's keep going. It falls right into this little groove right here. On the other hand, our enhancing structure makes a curl and goes backwards. It does not go into Dorello's canal, whereas the true abducens nerve goes into Dorello's canal. Then it continues on. We can't see it very well. It's right there. It goes on into the cavernous sinus, and I'll show that to you better in the coronal projection, and then continues on into the orbit through the superior orbital fissure to innervate the lateral rectus muscle. That is the apparent and real origin of the abducens nerve and abducens nerve nucleus. Let's move on, shall we? Pomerantz out. I'm going to share with you some tricks for finding the elusive, very small 6th nerve. Only the 4th nerve is more challenging. And here we are at the level of the portio major, mostly, of the 5th nerve. So if you find the 5th nerve and you go a little craniad, a little bit north of the 5th nerve, you're going to run into the 6th nerve, which has an anterolateral course out of the pontomedullary sulcus or inferior pons. Now, as it courses over obliquely from mesial to anterolateral, it's going to do something else. Let's look at the sagittal. Now, it's not easily appreciated, so I'm just going to draw it. It's coming out of the pons, and it's working its way up. So the nerve doesn't go straight. It goes slightly craniad or slightly north, where it then follows a course into Dorello's canal before it reaches the cavernous sinus. Now, here in the coronal projection, its identification is brutal. The only way I was able to identify it is I cross-reference this structure and that structure with these two structures. Now, we'll scroll them again, and you'll see how hard they are to pick up. You see them going back again, or forward, sorry. You see them going anteriorly. Now you lose them. Now let's go back. You have them again. There they are. There's one. There's two. And then they're going to go right back into the ponto midbrain sulcus, or the inferior pons. Now, a critical location for the abducens nerve is the cavernous sinus. Sometimes you have to infer its location. But one way to identify it is to go to the cavernous sinus, and you look for a series of dots. And the most mesial of the dots that's closest to the carotid artery is going to be the abducens nerve. There's your carotid artery. There is your white dot. There is your abducens nerve. And that is the nerve that is most prone to compression because A, it's small, and B, it's medial, directly adjacent to the cavernous portion of the carotid artery. So an aneurysm there may present with a 6th nerve palsy. And that's a wrap. Dr. P out. Dr. P here to talk about the 7th nerve or facial nerve. I'm showing you a gross diagram of the brain stem at the level of the pons. Here's the pontomedullary sulcus. You can see the apparent exit of the 7th nerve, but the real the real origin, this is the apparent origin, the real origin of the seventh nerve is in a nucleus. Now, what's curious is in this sagittal diagram, which is anatomically correct, the seventh nerve fibers course in the brainstem for a variable distance, loop around the nucleus of 6, the abducens nerve nucleus, and then move forward as they create the apparent origin of the seventh nerve. So let's look at that in the axial projection on an MRI. So I have before you a sagittal T1 high-resolution thin section image on the left, but pay no attention to that for right now. I want to focus your attention on the right side of the screen, the axial T2 high-res image. Here is the sixth nerve coming out anteriorly, but I am interested in the real origin of the seventh nerve. So let's take a look at this axial view at the level of the brachium pontus, the middle cerebellar peduncle, and we have some nice little colors here for you to make it a bit easier. And those colors include the superior and medial and lateral vestibular nuclei over here, the medial longitudinal fasciculus, which can be affected in multiple sclerosis. We've got the medial lemniscus more towards the midline as a fairly large yellow structure. And then we've got this triad right here, which we're going to focus on. This is the trigeminal and mesencephalic nucleus of 5. So let's ignore that for right now. And then we have 7 and 6. And we said 7 and 6 are pretty intimate with each other. And let's look at what 7 does. 7 has its nucleus, and the fibers then course posterior around the abducens nerve, pass in front of this green structure, which is the trigeminal and mesencephalic nucleus of 5, and then crosses directly in front of the trapezoid body, which is part of the hearing or auditory pathway, before it leaves the station in the region of the cerebellopontine angle. So this looping effect of the seventh nerve around the abducens nerve nucleus is the main teaching point of this vignette, along with the fact that you have this very close triad of nuclei at the apparent origin of 7, which includes 7, 5, and 6. Dr. P here talking about the seventh nerve, an important one. It travels with 2 other nerves. The sixth nerve right above it comes out of the pontomedullary sulcus and has an antero-superolateral course. It's a little distanced away from the seventh nerve, which has a more lateral orientation, but this portion of the nerve is intramedullary. And we're going to talk in the next vignette about the true origin of the seventh nerve. For the apparent origin, the one you see when you look macroscopically at the brainstem, is along the origin of the seventh and eighth nerve canal, right at the origin of the canaliculus. Traveling with the seventh nerve is this chubby pink nerve, and you can see they both have an antero-superolateral course or an anterolateral course. They travel together as the seventh and eighth nerve complexes, and they're actually going to be broken down into a 4-nerve group. You're going to have the superior and inferior vestibular nerves in the back, and the seventh nerve up and the cochlear nerve down in the front. So if you were going to produce a sagittal section of this area, something like this, or a sagittal oblique, and you were looking along the sagittal, this would be anterior, this would be posterior, so you'd have 4 nerves. There's 1, there's 2, there's 3, there's 4. And what are those 4 nerves? Well, those 4 nerves are 7 up, facial nerve, anterior, coke down. So this would be facial, this would be cochlear, and in the back you'd have superior vestibular and inferior vestibular. These are actually going to be divided up by the crista falciformis horizontally and Bill's bar vertically. Let's move on, shall we? Dr. P here with the seventh or facial nerve. Got a beautiful little diagram here that shows the intramedullary or real origin of the seventh nerve, which is located in the pons. But then we have exit at the pontobulbar sulcus. And that origin is going to come out in an anterolateral orientation with its chubby little neighbor, the eighth nerve. Now, my goal here is to talk about the apparent origin, which you see right here on this diagram, but also the segments of the facial nerve. So now let's utilize an MRI to look at the apparent origin of the seventh nerve, anterolaterally in the pontobulbar sulcus, and then look at the appearance of the seventh nerve and its relationship to some of the other structures around it as we decide on the individual segments of the seventh nerve. So I am going to look in the sagittal projection pretty much orthogonally like this. And when I do that in the sagittal projection, I end up with 4 dots. 1, 2, 3, and 4. Let's take a look at those 4 dots. We've got 7 up, like the soda, and Coke down, like the soda. 7 up right there. So I'm going to put a dot over that. Seventh nerve. Coke down, I'm going to put a dot over that. Then in the back, I've got the superior vestibular nerve and the inferior vestibular nerve. Now, those are divided by some septa, never mind if they're bony or fibrous for right now. And I'm going to make those septa in blue, dividing the top group from the bottom group is the crista falciformis, and then incompletely dividing from the top down, but particularly the cochlear nerve, the seventh nerve and the superior vestibular nerve is Bill's bar, or Bill bar. So we've got this almost T-shaped configuration. Some people actually draw Bill's bar all the way through, but it only goes about halfway through. So let's just review. 7 up, Coke down, superior vestibular, inferior vestibular. So now in the next vignette, let's drive home the individual segments of the seventh nerve. Dr. P here, back with the facial or seventh nerve. We've got a beat on the seventh nerve on our axial high-resolution T1 weighted image and our sagittal orthogonal image. Now, the nerve typically travels from the pons, from a nucleus, which we've defined in prior vignettes, that loops around the abducens and then comes out the side just at or above the bulbopontine sulcus. Now, when it exits, it's going to make this funny little loop right here. So if I were to draw the course of the seventh nerve, it would look something like this. It would come out, then probably have a small little opening there on CT, if you could see it, the fallopian canal, and then it would loop around where you've got the geniculate ganglion, and then it would kind of come back in a horizontal fashion, and then it would dive straight down into the screen and have its deep descent like this, exiting right there at the stylomastoid foramen, which will be somewhere around here. And we're going to show that to you in a moment. So that's the general course of the seventh nerve. Remember, it's 7 up, Coke down, so it's above the cochlear nerve. Don't get confused there. And it can be a little hard to distinguish the two in the axial projection unless you have uber thin sections. Now, the seventh nerve travels in close proximity with the eighth nerve, as we've said, but the eighth nerve is a rather complex structure. It consists of superior and inferior vestibular nerve as well as cochlear nerve, and we've defined these before. But the facial nerve supplies also preganglionic sympathetic fibers to the head and neck ganglia. The facial and intermediate nerves are collectively referred to as the nervus intermediofacialis, if you really want to get technical about it. Now, I want to talk about the 6 segments of the facial nerve now that I've drawn for you its basic course. The first is the intracranial cisternal segment, and that would be the segment in the cerebellopontine angle cistern. Let's put it up right here. So that would be the cisternal segment right there, right as it comes out. So that's essentially the apparent origin. Then we get into, let's use a different color here just to emphasize, we get into what's called the meatal segment, also known as the canalicular segment within the 7th and 8th nerve canal. Then we get into the labyrinthine segment, which is the internal auditory canal segment all the way up to the geniculate ganglion. I'm going to use a different color for emphasis. I'll try something a little light blue right here. So we're working our way towards the geniculate ganglion, which is going to be this little condensation, a little ball right there. And then we move on to the tympanic segment, which is from the geniculate ganglion to the pyramidal eminence. So let's use a different color for that. Oh, let's try something like green. So we're working our way back towards the pyramidal eminence. And then we keep moving to the mastoid segment, which is from the pyramidal eminence to the stylomastoid foramen. And we have that right here. It's going to be right there. I'm going to cross-reference it for you in a minute. But we have it in the sagittal projection. This sagittal view is going right through this spot right here and showing you the descent. We should use a different color to be consistent. Let's go with something purple. We're working our way down. Maybe it doesn't show up as well as I would like, but I think you get the point. And it exits the brain at the level of the stylomastoid foramen. And then finally, the extratemporal segment, which kind of goes off the screen right here. And we got to pick another color. Let's go with pink, one of my favorites. Goes from the stylomastoid foramen to the parotid branches. So that would be here and then going off the screen. So we have 1, 2, 3, 4, 5, and 6 segments of the facial nerve. Now, I promised you we would cross-reference, so let's cross-reference so we can see the stylomastoid foramen and the vertical portion of the facial nerve. There it is right there. That's it. Now, the reason that's important is sometimes you want to pay very close attention to that area. You follow it up, you follow it down, you follow it up. Here it is becoming extratemporal right there, headed towards the parotid gland. Now we're following it up. And when a patient has, say, Lyme disease or some type of facial nerve palsy like Bell's palsy, you want to see if that vertical segment is enhancing and compare the two sides. 6 segments, facial nerve, nerve number 7. Let's move on. Dr. P here talking to you about the motor and sensory portions of the facial nerve. I want to come back for a minute and talk to you about the motor facial nerve nucleus, which sits right here. And then we have the abducens nerve nucleus, which sits right under the facial colliculus bump. And we've already said that there's an intimate relationship between the two, as the motor fibers predominantly are going to loop around the abducens nerve and then kind of come out the side, where they then hit the canalicular portion of the facial nerve. So now let's look at that portion of the facial nerve. It's going to be higher than the cochlear nerve, so you've got to go up to see it. And then as it comes out right here, we reach the labyrinthine portion of the facial nerve. Then it's going to make a little curve. Let's make that curve known as the genu, and you'll have a little condensation, the geniculate ganglion. Then it has a horizontal course before it dives vertically, heading towards the parotid gland and stylomastoid foramen. Now, when you're in the brain stem, you've already seen the main facial nerve nucleus in the pons, but there is also a sensory and parasympathetic component to the facial nerve, and this is known as the intermediate nerve or nervus intermedius. So from the brain stem, both the motor and sensory parts join together, and they traverse the posterior cranial fossa before entering the petrous temporal bone via the IAC or internal auditory meatus. And then they exit the meatus as we just discussed. So the take-home point here is you have both sensory and motor components, although the motor component is most famous and dominates the two. The lesser component known as the nervus intermedius, and you've also learned that there is, right at the genu, a geniculate ganglion, which will be discussed at a later date. Let's move on, shall we? Dr. P here with the 7th or facial nerve. I want to make 3 points. First, the 7th nerve has 2 bends. One bend is known as the genu. It occurs in front, and this is also known as the geniculum of the facial nerve. Genu means knee, and it contains the geniculate ganglion. You can actually see the ganglion right here as this gray little blob that is covered by this whitish area, which represents the petrosal plexus of veins right next to it, coursing alongside portions of the horizontal tympanic facial nerve. And those will come back to the second curve in the nerve. So we come back to the second curve. Now we can't see that curve because that curve goes down into the screen as the vertical segment and then exits from the stylomastoid foramen. So we've established that there's 2 curves, one curve here at the genu with the geniculate ganglion and the other curve in the back. Now if we try and cross-reference the geniculate ganglion, which is our second point of interest, the geniculate ganglion is right here in the sagittal projection. This is a magnified sagittal view, so this would be anterior, this would be posterior. I'll minify it a little bit so you can see where you are. So here's the cerebellum back here. Now it's really hard to see the ganglion, but you can see what a challenging structure it is to see. And then the next point I'd like to make is the first branches that come off from the facial nerve. Now, the reason I chose to show you the geniculate ganglion is that's a marker for where these branches come off, because you can't really see them. And these include the greater superficial petrosal nerve, which arises right there. And the greater petrosal nerve runs through the pterygoid canal, its synapses in the pterygopalatine ganglion, and postsynaptic fibers of the greater petrosal nerve innervate the lacrimal. In the tympanic segment, the facial nerve runs through the tympanic cavity medial to the incus. We can't really see that here, but it's more of a horizontal component to it. And then it reaches its second bend where it runs in a vertical orientation. So in the temporal part of the facial canal, the nerve gives rise to a few more branches, to the stapedius and to the chorda tympani. And the chorda tympani supplies taste to fibers to the anterior two-thirds of the tongue and also synapses with the submandibular ganglion. Now, postsynaptic fibers from the submandibular ganglion supply the sublingual and the submandibular glands. Let's move on. I'm back with some more distal branches of the seventh or facial nerve. I've got a sagittal T1 and an axial T1. Now, my sagittal T1 is taken all the way out here. And these two dots right here represent the seventh nerve, up, cochlear nerve, down. I'm going to ignore the cochlear nerve right now, and we're right at the locus of the geniculate ganglion. So we're right over here in the axial projection. Now I'm going to follow the seventh nerve, and right around the geniculate ganglion we have the genu, or the knee, or one of the curves of the seventh nerve. I can follow it forward, and now I can follow it back. It travels with the petrosal plexus of veins, so it's a little bit brighter normally. You don't want to confuse that with enhancement. It's just flow phenomenon. And now as we follow it back, we see our second curve right here. And it curves down into the vertical segment of the seventh nerve, which corresponds axially to this structure right here. So what branches come out at this locus? The posterior auricular branch in the descending portion before it exits the cranial vault or cavity and then passes through the parotid gland. Now, it doesn't innervate the parotid gland, but it does form a parotid plexus, which splits into 5 branches innervating the muscles of facial expression. And these can be remembered with the acute mnemonic, 2 zebras bit my cow. T for temporal, Z for zygomatic, B for buccal, M for mandibular, and C for cervical. Let's move on, shall we? Dr. P here with the seventh nerve. Just want to say a few words about the distal branches of the seventh nerve. You may have gotten the impression the posterior auricular nerve comes off over here. It actually comes off right as the nerve leaves the stylomastoid foramen. It's not a nerve that you can see, but you can follow the facial nerve down, and you should as it exits the brain. There you have it right there. Still have it, still follow it, and now it is starting to head towards the parotid gland. So I just want to say a word about the posterior auricular nerve again. It controls movements of some scalp muscles around the ear, as a branch to the posterior belly of digastric, as well as the stylohyoid muscle. The reason I mention it is nobody ever thinks about what that nerve does. And then as it moves into the parotid gland, you remember the mnemonic, 2 zebras bit my cow, and this formulates the mnemonic for the branches in the parotid plexus, temporal, zygomatic, buccal, marginal mandibular, and cervical branch. So now I'd like to move on and cover in the next vignette the petrosal nerve, which is an important one. Dr. P here talking about the greater petrosal nerve, a branch of the facial nerve. It's an important nerve, but it's one that doesn't get a lot of attention. It arises at a locus where the geniculate ganglion provides a marker. So here's your geniculate ganglion right there, and here is the curve, the genu of the facial nerve right there. It's hard to see the curve, but I'll draw it so you can fantasize it. And I'm going to put a little color on it. And then coming forward in an oblique fashion is the greater petrosal nerve. Now there's some high signal here because there's a petrosal plexus of slow-flowing vessels right there that contribute to that hyper or apparent hyperintensity. The greater petrosal nerve provides parasympathetic innervation to several glands, including nasal glands, palatine glands, the lacrimal gland, and the pharyngeal gland. It also provides parasympathetic innervation to the sphenoid sinus, the frontal sinus, the maxillary sinus, the ethmoid sinus, and the nasal cavity. This is an important nerve. It also has taste fibers for the lesser palatine nerve and the palate, and also the greater palatine nerve. It contributes to the otic ganglion, and it arises again at the level of the geniculate ganglion where it joins the lesser petrosal nerve to reach the otic ganglion. In the sagittal projection, if you want to find that nerve, you can just cross-reference. Let's take our little cross-reference marker right here. There is our geniculate area right there, and just in front of it, you're going to find the greater petrosal nerve. So right there is going to be the greater petrosal nerve, which again is slightly hyperintense for reasons we already mentioned. Dr. P out. Dr. P here to talk about the eighth cranial nerve, the vestibular cochlear nerve, which transmits sound and equilibrium or balance information from the inner ear to the brain. My point today in this vignette is to show you some of the key components of the real origin of the hearing mechanism. And real means nuclei. Where are these nuclei located? They're located in the pons, laterally, kind of close to the middle when we talk about from anterior to posterior, from here to here, right about in the middle. You can see the seventh and eighth nerve right there. That's the eighth nerve. And these nuclei are paired on each side. There is a ventral and a dorsal one. The fact that we have two paired nuclei on each side and some additional reasons explain why you don't often get central hearing loss with a brainstem lesion. Now we've got a structure that courses from one side to the other. I think I'll make that kind of orangey yellow, and it's got a course that is slightly oblique from one side to the other. And I'd also like to draw the nuclei in the coronal projection too. So let's pair up our cochlear nuclei, which are located right at the bottom of the basis pontus right here on each side. And now let's draw our crossing structure, which is known as the trapezoid body or trapezoid pathway. Comes over to the side. Not only does it have a slight anterior course, it also has a slight superior course. And then it connects with the superior olivary nucleus. And there is a lateral and a medial one. Now, from there, we've got a very important tract. And that tract is the lateral lemniscus, which is part of the auditory pathway. Let's give it its due. I think green would be appropriate. And it's coming up this way. Now, I'm not going to scroll my coronal, but it's coming up in a rather dorsal position. And when it hits the top, what's it going to hit? The inferior colliculus. So I'm going to draw the inferior colliculus as a round structure, and then I'm going to scroll to it in a second. I'm going to use dark green for that. And now I'm going to take my colors away, and I'm going to go right to the inferior colliculus, and you'll see it's right there. There's the inferior colliculus. So the inferior colliculus is one of the way stations for the vestibular cochlear system. Then an arm of the inferior colliculus goes out to the side to the medial geniculate nucleus, then on to the transverse temporal gyrus of Heschel and the planum of the temporal lobe. One more thing about the apparent origin of the seventh and eighth nerve complex. I want to scroll up a little bit because I showed you the lateral lemniscus heading north in the coronal projection, and I'm going to take a unique color, something we haven't used before. Let's try light blue. And our lateral lemniscus is coming up this way from the superior olivary nucleus, which has medial and lateral components. It goes to the inferior colliculus before it goes out sideways to the medial geniculate nucleus. But where is the lateral lemniscus in the axial projection? It's located dorsolaterally right about here. So more posterior than the paired cochlear nuclei, which are located somewhere mid-coronal from A to P. That's a pretty complicated explanation of the apparent origin of the vestibular cochlear system. Dr. P out. Now let's talk about the apparent origin of the seventh and eighth nerve complex, or cranial nerve 8, which goes into the lowermost portion of the brainstem pons at an oblique orientation. Now this is a little bit poorly understood or not well recognized, that it's the lowermost aspect of the pons that the 7th and 8th nerve complex comes off almost to the level of the medulla. If we cross-reference the cochlear nerve right there, look where it is, right close to the pontomedullary sulcus. Now, if we talk about the 8th cranial nerve running between the base of the pons and the medulla oblongata, or the lower portion, it is this cistern right here, which is known as the cerebellopontine angle cistern, which is quite important. Another name given to this is the cerebellopontine angle. So here is your cerebellopontine angle right there. The vestibulocochlear nerve is accompanied, by the way, by a very tortuous structure. You can see a little bit of it right there. This connecting antero-posterior oriented area of flow void known as the labyrinthine artery, which arises from branches of the anterior-inferior cerebellar artery, or ICA, at the cerebellopontine angle, and goes with the 8th nerve into the internal acoustic or auditory meatus. Dr. P.L. I want to finish up our discussion of the cochlear vestibular or 8th nerve by starting with the cochlea. The nerve comes away from the cochlea. There's the medullus of the cochlea. There's the spiral lamina, and the high signal intensity represents the components of endolymph and perilymph in the otic capsule. Now, the spiral ganglia are where the nerve starts. Then it becomes a nerve, and it travels through the internal auditory meatus and then enters the ponto-midbrain sulcus, or just above the ponto-midbrain sulcus, at the cerebellopontine angle. Now, there's a nerve in front and a nerve in back. When you're at the level of the cochlear nerve, since it's 7 up, coke down, you're at the level of the inferior vestibular nerve. When you're at the level of the facial nerve, you're at the level posteriorly of the superior vestibular nerve. Or, said another way, let's draw. So if I were to produce a sagittal oblique like this or this, and then I had you look at that sagittal oblique, you'd see 4 round structures like this. So this would be anterior, this would be posterior, and high up front, you would see the facial nerve. So 7 up, coke down. Here would be your cochlear nerve. And in the back, you'd have the superior vestibular nerve and the inferior vestibular nerve, and these would be separated by the crista falciformis and might be partially separated vertically by the structure known as Bill's bar. Let's move on, shall we? Dr. P here with the glossopharyngeal nerve, also known as the 9th cranial nerve. It's a mixed nerve that carries afferent sensory and efferent motor information. Now, it exits the brainstem from the sides of the upper medulla, and you can see that we're not at the upper medulla, we're at the level of the pons, and the reason is, I want to give you a landmark. Got the 7th and 8th nerve complex exiting anterolaterally. In front of that, we also happen to have, coincidentally, nerve 6, and now we go down. And as we go down, if you can count from 7 and 8, you're going to run into nerve number 9, and there it is. And with it, you have traveling some other nerves, 10 and 11, right behind it, along the posterior aspect of the upper medulla. Now, for you wine lovers out there, and for you medical students and residents, the glossopharyngeal nerve participates in taste, along with the chorda tympani coming from the 7th nerve, which travels with the lingual nerve, which is part of the 3rd division of the trigeminal nerve. So that gets the anterior 2/3 of the tongue for taste, while the glossopharyngeal nerve gets the posterior 1/3. Now, the motor division of the glossopharyngeal nerve is derived from the basal plate of the embryonic medulla oblongata, while the sensory division originates from the cranial nerve crest. Now, let's have a look again at the apparent origin of the glossopharyngeal nerve. If we tack a little cursor right here, right there in the coronal projection, you can see with a slightly upward course in this individual is the glossopharyngeal nerve. Right there, just to the right of the brainstem, upper portion of a medulla, and there it is coming right out of the medullary region, the apparent origin of the glossopharyngeal nerve number 9. Dr. P here talking about the glossopharyngeal or 9th cranial nerve arising from the medulla oblongata. Here's 9, 10, and 11 right here. And the nerve passes anterolaterally. So let's go down. Now, it courses right next to the flocculus, part of the flocculonodular lobe of the cerebellum. Here's the flocculus. So you can see the close proximity of the glossopharyngeal nerve to the flocculus. Here's the glossopharyngeal nerve. There's the flocculus right next to it. And then we follow it into the region of the jugular fossa, which is going to be right here. Now, it's difficult to follow contiguously, but you see part of it right there. And again, we're going to talk about nerves 9, 10, and 11 together. They're all going into the jugular foramen through the central part of the jugular foramen. Not as easily seen on this T1 weighted image, but it is seen as it is on this T2 weighted cisternographic image. Now, as the nerve hits the jugular foramen, I want to talk about what happens in here, which is very difficult to see anatomically. But you've got superior and inferior ganglia in the jugular foramen, and they have their own sheath of dura mater. The inferior ganglion sits on the inferior surface of the petrous part of the temporal bone and is related with a triangular depression into which the aqueduct of the cochlea actually opens. Let's have a look at that anatomic information on CT. So on this accompanying CT image, you see a triangular shaped space in the region of the jugular fossa with the jugular tympanic spine, and this is known as the petrosal fossula and contains the inferior ganglion of 9. Dr. P out. Dr. P here. I want to talk about the exit of the glossopharyngeal nerve and its related nerves, the vagus and spinal accessory nerves, from the brain into the jugular foramen. Now, if we follow the nerve right here from the medulla, and right anterior to it is this darker, slightly bigger tubular structure right there, which you can see has some high signal. That's a vessel, a pica or a branch of pica. The glossopharyngeal nerve is behind it, and it sits anterior, and then as we go down, anterolateral to its companion, the vagus nerve. So now let's follow it out laterally. You can follow on the T1 if you want, but it's better seen on the MR cisternogram. And as we get out here more distally, there it is. It's located between the carotid artery, so it passes between the carotid artery and the jugular vein. Now it's going to descend in front of the latter vessel, namely the jugular vein, so it's going to be right in front of the jugular vein. And if you can see it on CT, beneath the styloid process and the muscles connected with it. So that's the lower border of the stylopharyngeus. It then curves forward or anteriorly, we're not going to be able to see it here, forming an arch on the side of the neck lying directly upon the stylopharyngeus and middle pharyngeal constrictor muscles. That is the exit of the glossopharyngeal or 9th cranial nerve. Dr. P out. Dr. P here, talking about the 9th cranial glossopharyngeal nerve. I want you to remember 3 components as we talk about the real origin in the medulla oblongata of the glossopharyngeal nerve, and they are the nucleus ambiguus, the inferior salivary nucleus, and the solitary tract nucleus. So let's see where we are. We're at the level of the restiform body. Just for giggles, let's mark something we all know. We'll mark it in red. It's a motor pathway just to get the motor pathway set, and this is known as the pyramid. And then we have the anterior midline sulcus between the 2 pyramids. So now we've got a couple of other what I call motor pathways that participate in the motor supply of the glossopharyngeal nerve. First, we've got the nucleus ambiguus, which is kind of right off the midline, a little bit behind center. Then we've got, and I've drawn it a little bigger than it really is, just so you can see it. Then you've got more posteriorly, just under the 4th ventricle, the nucleus of the solitary tract. That's also going to give rise to some motor function. And now let's switch over to some other color that represents a sensory contribution, which is the nucleus of the solitary tract, which sits just lateral to the inferior salivary nucleus, and now we have it. So now if we draw the apparent origin, we've got the sensory, and then we've got the contribution of the motor right here. These 2 give rise to the motor component of the of the glossopharyngeal as they come out, and they sort of travel together as one. You really can't separate them out. I've just separated them out anatomically for your perusal and educational interest. Now, the motor fibers arise in the medulla oblongata at the upper part of the nucleus ambiguus, which, by the way, receives central fibers from the precentral gyrus via the corticonuclear tract. They begin their course in the back medially and down toward the floor of the 4th ventricle, but they swerve pretty sharply to the side before merging with the sensory roots. And you can see that sharp lateral swerve, and then the sensory root comes together with the motor root to produce the glossopharyngeal nerve, the real origin of the glossopharyngeal nerve, sensory and motor, at the medulla oblongata, remembering the three major components: nucleus ambiguus, inferior salivary nucleus, nucleus of the solitary tract. Dr. P out. Dr. P here, summarizing the ninth cranial nerve. We learned that there are three real origin components of the glossopharyngeal nerve at the level of the medulla oblongata. We've got the nucleus ambiguus, which is just posterior to the midcoronal plane, close to the midline. We've got the inferior salivary nucleus, and although I haven't divided them up into sensory and motor this time, we've also got a little more lateral to that, the nucleus of the solitary tract. And these three are going to contribute to both sensory and motor components of the glossopharyngeal nerve to create the apparent origin of the glossopharyngeal nerve, which travels very nicely with its companion, the vagus nerve, which I'll draw over in red right here. So then these nerves go out to the side, and we're going to come off now our drawing tool, and we're going to go down, and the nerve sits between the carotid artery and the jugular vein, traveling inferiorly, as we discussed before. Now, the branches include tympanic, stylopharyngeal, and tonsillar. There's a nerve to the carotid sinus, branches to the posterior third of the tongue, which participate in taste, and these are known as lingual branches. There's also a communicating branch to the vagus nerve. It's important when you're taking any board exam that you remember the glossopharyngeal provides taste to the posterior third of the tongue. Taste to the anterior two-thirds of the tongue comes from the chordotympani nerve, from the facial nerve, traveling with V3, the third division of the trigeminal nerve. The glossopharyngeal nerve also contributes in the formation of the pharyngeal plexus along with the vagus nerve, and has motor supply to some of the constrictor muscles and muscles of the pharynx. Dr. P out. Dr. P here with our friend, and sometimes our enemy when we're not feeling so well, the vagus nerve. Historically, it's cited as the pneumogastric nerve. It's also known as the 10th cranial nerve, and it interfaces with the parasympathetic control of the heart, the lungs, the digestive tract, and the vagus nerves are paired, but they're normally referred to as the vagus nerve in the singular. It's the longest nerve of the autonomic nervous system in the entire human body. It leaves the medulla oblongata between the pyramid in front and the inferior cerebellar peduncle or restiform body in the back. And there it is. We've got our glossopharyngeal nerve right here and here. This one is right behind a branch of pica. And then behind that is the vagus nerve. So the vagus nerve is sort of posterior and a little mesial as we get out laterally to the glossopharyngeal nerve. And then we can follow it peripherally. So we're going down now. And as we get into the jugular foramen, it's going to sit between the jugular vein and the carotid artery. Same thing on this side. The jugular vein doesn't have flow phenomenon here, but here's the jugular vein right there. There's the carotid artery. So the vagus nerve is going to be sitting right in this locus at this level. It then passes into the carotid sheath between the internal carotid artery and the internal jugular vein down into the neck, the chest, and the abdomen, where it contributes to innervation of the viscera, reaching all the way, believe it or not, to the colon. Dr. P out. Let's take a look at the real origin of the vagus nerve. Now, this is a little bit tough. We've got three sensory components, and I'm going to use my beloved blue color to demonstrate them. We've got the dorsal sensory nucleus, which is pretty small, sits right about here. Then we've got the round nucleus that sits right next to it, slightly posterior and lateral to it, and that is also a sensory component. And then we have the nucleus of the solitary tract, which contributes to 9 and 10. That's going to be over here. Now let's go for some motor contribution, real origin structures. And these you're familiar with from the glossopharyngeal nerve. One is the nucleus ambiguus, and it contributes, actually it's a little more posterior right about here. Do a little racing right there. And then we've got posterior to that, and a little more medial right under the fourth ventricle is the inferior salivary nucleus. and the inferior salivary nucleus actually travels just mesial or medial to it is the spinal nucleus of the vagus nerve, which I'm just going to put as a little blip with another little red dot next to it. So that is the real origin of the vagus nerve. Now, besides giving some output to various organs, the vagus nerve comprises between 80 and 90% of afferent nerves, mostly conveying sensory information about the state of the body's organs to the central nervous system. The real origin of the vagus nerve, rather complex, giving rise to the actual apparent origin of the vagus nerve, which has an anterolateral course and then reaches a space between the carotid artery and the jugular vein. Dr. P here. I want to talk to you about the descent of the vagus nerve. Now, here's the vagus and glossopharyngeal nerve. As we work our way down, you can see the nerves crossing anterolateral, and you're going to follow them into a space right between the internal carotid artery and the jugular vein. Now, I'm going to go down as far as I can, and this is where you're going to find the vagus nerve on your way down, traveling between these two structures. So sometimes you're going to have to infer its location, and this is especially important when you're looking at glomus vagale tumors or schwannomas of the vagus nerve. Now, I'm going to go as low as I can. I've got the internal carotid artery. I can't see the external branches all that well, and I'm not down to the level of the common carotid artery yet, but that's relevant. So keep these two structures in mind. For the right and left vagus nerves descend from the cranial vault through the jugular foramen, and they penetrate the carotid sheath between the internal and external carotid arteries, and then they pass posterolateral. We're not at the level of the common carotid artery, but if this were the common carotid artery, the perforation is kind of in a posterolateral orientation to the common carotid artery into the carotid sheath. Now, for those of you that are medical students or studying for anatomic exams, the cell bodies of the visceral afferent fibers of the vagus nerve are located bilaterally in the inferior ganglion of the vagus nerve, which is known as, board question, the nodose ganglion. Now, the right vagus nerve gives rise to the right recurrent laryngeal nerve, which I'm not going to show now because we're in the brain, and it hooks around the right subclavian artery and ascends into the neck between the trachea and the esophagus in the right tracheo-esophageal groove. The right vagus then crosses anterior to the right subclavian artery. It runs behind the superior vena cava and descends posterior to the right mainstem bronchus, and then contributes to cardiac, pulmonary, and esophageal plexuses. It forms the posterior vagal trunk as the lower part of the esophagus, and then it enters the diaphragm through the esophageal hiatus. Now, you can stop right now if you want, but for you med students and residents out there, the left vagus nerve then enters the thorax on the opposite side between the left common carotid artery and the left subclavian artery, and it descends on the aortic arch. It gives rise to the left recurrent laryngeal nerve, which hooks around the aortic arch to the left of the ligamentum arteriosum and ascends between the trachea and esophagus in the left TE groove. The left vagus further gives off thoracic cardiac branches. It breaks into a pulmonary plexus. It continues into the esophageal plexus. And finally, it enters the abdomen as the anterior vagal trunk in the esophageal hiatus of the diaphragm. Probably more than you wanted to know, but Dr. P out. Dr. P here. I just want to talk a little bit about the function of the vagal nuclei at the level of the medulla oblongata. There's actually 5 of them. Some books say 4, but 5 is probably the right number. And there's a lot of function of the vagus nerve, as you've heard. There's also a pharyngeal nerve, the superior laryngeal nerve. There's superior cervical cardiac branches, inferior cardiac branches, and the recurrent laryngeal nerve. So a lot of laryngeal function is happening on behalf of the vagus nerve. Now let's look at those 5 nuclei. We've got the dorsal sensory nucleus, which is a little more medial and posterior right there. Then just behind it is the round nucleus. And then the third one is the nucleus of the solitary tract. And that one is a little more lateral. They kind of form a triangle right here. And some of these are going to contribute to 9 as well as 10. Then we get into 2 of the motor contributors. We've got the nucleus ambiguus, is slightly off midline right here, maybe a little further back than that. And then we've got the second one, which is the nucleus of the solitary tract, which lies just in front of this little triad here and sits a little more medial than the nucleus of the solitary tract. So these 5 participate together, and the vagus nerve includes axons which emerge or converge from all 5 of these nuclei. Now, the dorsal nucleus sends parasympathetics to the viscera, especially the intestines. The nucleus ambiguus, which is right here, gives rise to the branchial efferent motor fibers of the vagus nerve, and preganglionic parasympathetic neurons then innervate the heart. Pretty darn important. Then the solitary nucleus, which receives afferent taste information and primary afferents from the visceral organs, and the solitary nucleus is going to be right here. And then finally, one that we haven't discussed, one you can kind of add on to these 5, the spinal trigeminal nucleus. I'm not going to draw it. It receives information about deep, crude touch, pain, and temperature of the outer ear, the dura of the posterior cranial fossa, and mucosa of the larynx. And if you want to see more about that nucleus, you can go to the discussion of nerve number 5. That concludes our discussion of the nuclear function for the vagus nerve. There are at least 5, maybe even 6 nuclei that are participating. Dr. P out. Dr. P here to talk about the spinal accessory or accessory nerve, nerve number 11. It's a cranial nerve that supplies the sternocleidomastoid and trapezius muscles, and it's considered the 11th of 12 pairs of cranial nerves. It was formerly believed to originate in the brain, but that's no longer really accepted dogma. As you know, the sternocleidomastoid muscle tilts and rotates the head, while the trapezius muscle, connected to the scapula, acts in shoulder shrugging. So here we have an axial image, level of the pyramid and restiform body. That's a vessel right there. There's your glossopharyngeal nerve right there. Here is your vagus nerve. And right behind that, this little reet or complex posteriorly, the third of these 3 nerves, A, B, and C right there, is the lowermost portion of the spinal accessory nerve. Now, the spinal accessory nerve has traditional descriptions that divide it up into a spinal part and a cranial part. The cranial component rapidly joins the vagus nerve, so there's some debate about whether the cranial part should actually be considered part of the spinal accessory nerve. And we're going to get into those 2 major contributions, one up higher, one down lower, in the sagittal projection in the next vignette. Dr. P here talking about nerve number 11, the spinal accessory nerve, but the term accessory nerve really refers only to the nerve supplying the sternocleidomastoid, the trapezius muscles, and therefore it's known as the spinal accessory nerve. Let's draw off the sagittal projection. First, the rostral or cranial component, which is formed by the spinal nucleus of 11. It sits higher up than you would think. It's pretty elongated, and it's not so anterior in its position as the true accessory nerve. So this gives rise to multiple rootlets inside the upper medulla oblongata, and then they converge as a nerve that leaves off to the side. Now we're in the midline, but just for education's sake, the nerve is coming out laterally, coursing anterolaterally, then kind of dips down a little bit before it merges with branches of the vagus nerve. Now, the one we're really fixed on right now is the true accessory nerve component of nerve number 11. It's further caudal. It's pretty elongated. It's also more anterior, and it dips down into the upper cervical region. So it's medulla oblongata and upper cervical, and this time the roots come together in a very short fashion, and then they coalesce as the apparent origin of this component of nerve number 11, and then it loops upward. It has a pretty steep upward course before it kind of bounces off the craniad component and then dips down and courses lateral and posterior to innervate the trapezius. Now, injury to the spinal accessory nerve is most commonly caused by medical procedures that involve the head and neck. Injury can cause wasting of the shoulder muscles, winging of the scapula, and weakness of shoulder abduction and external rotation. The accessory nerve is derived from the basal plate of embryonic spinal segments C1 through C6. So if we look at the coronal projection, we'll take our arrows off now, and we scroll off to the side. and try and locate the position of the accessory component of nerve number 11, you can see a little wisp of it right there corresponding to this locus right here. Not so easy to see in the coronal projection because of its diminutive size. You can see its companion on the contralateral right side, and as we said, it loops upward. You can see this one looping upward on the right, where it will join the unseen cranial division of nerve number 11. Dr. P here talking about the 12th cranial nerve, the hypoglossal nerve, which innervates all of the extrinsic and intrinsic muscles of the tongue, except for one. Which one? The palato-glossus muscle, which is innervated by the vagus nerve. The hypoglossal nerve is the sole nerve with a purely motor function. I love this nerve because it innervates the tongue, and my father told me the tongue is the most dangerous organ in the body, too much eating and too much talking. Now, the nerve arises from the hypoglossal nucleus in the brainstem, which we'll talk about separately, but it comes out as a number of small rootlets. Now, we can't see these rootlets, but I'm going to draw where they would be and how you would locate them. So you find this olivary bump right here, and you identify the olivary bump in the coronal projection, and right behind that olivary bump, you're going to have the rootlets coming directly out in a somewhat caudad fashion. They're going to converge very quickly within, well under a millimeter into a single nerve. I'm making it a little bigger so you can see it, where they'll enter the hypoglossal canal and then down through the neck, eventually passing up over the tongue muscles, supplying the tongue. There are two hypoglossal nerves in the body, one on the left and one on the right. Let's take a look at the hypoglossal nerve in the axial projection where you can see it a little better. Best seen this time on the T1. Now, because it's going caudal, I have to scroll caudal to continue following this. You can see it's right behind this protuberance right here. Now let's try and follow it. We can see a little bit of it right there. And then we kind of lose it for a short period of time. And then it comes back right in the hypoglossal canal. There it is, this linear, darker structure. I might even have to blow it up a little bit. Let's do that, just so you can see it a little better. Right there in the hypoglossal canal. And if we want to cross-reference it, there's the hypoglossal canal in the coronal projection. So if you were looking for a hypoglossal, say, schwannoma, and you saw tongue atrophy, these would be two places to go, here and here, where you are prone to get these. Dr. P here talking about the hypoglossal nerve. As you saw in the last vignette, this nerve will penetrate the lateral mass of the occipital bone as the hypoglossal canal. To see the canal, you have to go down and a little bit lateral, which we'll do in a minute. There's the hypoglossal nerve, but I want to clarify one thing. There's a little bump right here, which is actually the pyramidal bump. And behind that, if we scroll a little bit up and down, you can see a second little bump. There's your second little bump, the olive. So this is going to be a pre-olivary position of the hypoglossal nerve, whereas 9 and 10 are going to have more of a post-olivary, more posterior position, as you saw on earlier vignettes. Then as we scroll down, we lose the nerve for a little bit, kind of gets buried and hidden by the pulsation phenomena and anatomy of the vertebral artery, but there is our hypoglossal canal with an anterolateral course. We said there are multiple rootlets that converge into one nerve, sometimes two nerves traveling together, but no more than two trunks is what you see with the hypoglossal nerve. Now, the hypoglossal nerve passes through the subarachnoid space. It passes the dura mater in the hypoglossal canal and in the opening of the occipital bone as we described. But after emerging, it gives off a meningeal branch. It picks up a branch from the anterior ramus of C1, and you can start to see those branches as we scroll downward right here. Here are some of the branches down lower of the upper cervical region, C1, and then it travels close to the vagus nerve and spinal division of the accessory nerve, spiraling downward behind the vagus nerve and passes between the internal carotid artery and the internal jugular vein lying on the carotid sheath. So it's going to sit as you would expect, because 12 comes after 10 and 11. It's going to sit behind the vagus nerve as it descends. Dr. P, out. Dr. P here to talk about the real origin of the hypoglossal nerve, namely the hypoglossal nucleus. Now, I've got the hypoglossal nerve right there. I've got a couple bumps that we talked about previously. We've got a bump anteriorly, the pyramid, and you've got the olivary protuberance right here. So in a pre-olivary position sits the hypoglossal nerve. Now, what does the nerve do? Well, when it comes in, it actually has a posteromedial course where it sits directly underneath the fourth ventricle as the hypoglossal nucleus. Now, there are two paired nuclei, so there's obviously a hypoglossal nerve coming out the other side as well. I've drawn it a little bit crooked, but no matter. And the hypoglossal nucleus receives input from both motor cortices, but the contralateral input is dominant. So innervation of the tongue is essentially lateralized. Signals from muscle spindles on the tongue travel through the hypoglossal nerve, moving onto the lingual nerve, which synapses on the trigeminal and mesencephalic nucleus of nerve number 5. There's also important contributions to the tongue musculature. So in summary, the hypoglossal nerve, or the 12th cranial nerve, arise from paired nuclei in the most caudal aspect of the brainstem, posterior, underneath the fourth ventricle. The nerves course in the medullary space, in other words, in the medulla oblongata, anterolaterally. There's the apparent exit, then courses laterally where it reaches the hypoglossal canal, and then descends behind the vagus nerve in the carotid space. Dr. P, out.